Good morning and warm welcome to Online Anaesthesia postgraduate teaching program on Zoom platform sponsored by Aquila and hosted by A1 Logics and simultaneously aired by Anaesthesia TV. Today we are hosting an interesting must-watch session for the postgraduate, that is the research methodology. Today we have three eminent scholars among us. The session will be coordinated by Dr. Balabhaskar. The first topic is the new PG batch, new challenges, choosing the right research question for the dissertation by Dr. Balabhaskar. He is working as a professor in the Department of Anesthesiology, WIMS Bellary. He is the editor-in-chief of IJA during the year 2013 to 16. He is the past president of IAC National in 2019. He is the chief coordinator for formulation of 5 IAC practice guidelines. And he is the member and publication committee of World Federation of Society of Anesthesiologists. And his area of interest is research, guidelines, and educations. He has more than 50 publications on his own. So over to you, sir.
Good morning, Dr. Edward, and your team of Anaesthesia Online. Nice to be here as part of a very important discussion and presentation from my group, basically addressed towards the postgraduates. So these are certain sections which are very confusing to all of us, even as teachers. So, and the students definitely, when we are not totally in the know about what is happening, so it's always possible that PGs also could be in a lot of confusion. So it's our duty to see that all the doubts are cleared as much as possible from our point of view. So we have the first topic I'm going to speak about, actually Dr. Edward has told. It's mainly about choosing the research topic for the dissertation. The next one will be about implementation, broadly, how the plan that is created is implemented. That is methodology by Dr. Sudhish. And the third part is actually how we write the dissertation at the end. So it is true that good quality work is done everywhere, but always we also find that we miss something. So that always happens. So that's the reason this topic has been taken today. New PG batch and new challenges, that itself represents the problem for all of us, mainly because, yes, PGs have been there in different medical colleges. They are admitted every year, but the problem has become a little bit profound, mainly because of the increase in the number of postgraduates in different medical colleges. And possibly the number of clinical material that is available is not that much increased. So that brings certain pressure on the guides with respect to allotting the topics for the different postgraduates. So I'm specifically going to declare that I don't have any conflicts of interest because I am not an authority in this. It's mainly based upon the knowledge gained and input received from different colleagues from across the country. So I am not intending to question or challenge the knowledge, wisdom, and experience of the guides and the teacher colleagues from different parts of the country. And we cannot avoid it also because NMC mandates that we have a dissertation be taken up by the postgraduates. And in fact, it is highlighted in the competency-based medical education curriculum of NMC for post-graduation in anesthesiology. It says that every postgraduate student shall carry out work on an assigned research project under the guidance of a recognized postgraduate teacher. So this is what is picked up, extracted from the NMC CBB guidelines, the result of which shall be written up and submitted in the form of a thesis. So this is required for the postgraduates. And it's also important that it adds to the development of a spirit of inquiry in the postgraduates. This is a preparation of the postgraduate for the future also, and exposing the PG student to techniques of research, critical analysis, acquaintance with the latest advances in medical science, manner of identifying and consulting the availability. This last part also is very important because they are expected to become probably research in the future also. And of course, under the psychomotor domain, it says the PG must be able to demonstrate his or her ability to analyze the data and write a thesis, present scientific data, and participate in anesthesia audit also. And NMC has suggested the time frame for training to the students, because when we take up the topic today, even the time frames are very important. The first 6 months is he or she should select the thesis topic and submit the protocol for his or her thesis. Next 18 months, again, as per the NMCs, the student should be able to analyze the data and write a thesis. He or she should be able to present scientific data. Last 12 months, the thesis shall be submitted with minimum of 6 months before the final limit examinations. So these are the mainly important requirements from NMC, and the NMC also highlights the importance of dissertation in terms of assessment of the students. Under the formative assessment section, it says that the thesis is assessed separately. Under summative assessment at the end of the training, it says the final examination consists of 3 parts: the thesis, the theory evaluation, and the practical evaluation. All of us, yes, we know about theory evaluation and practical evaluation, but NMC also stresses on the importance of thesis as part of evaluation. And I know some of the universities are implementing, and some of the medical colleges, wherever we go as examiners, it's not taken too seriously, but it is there as part of NMC mandated requirement. And lastly, you just see this sentence: a postgraduate student shall be allowed to appear for the theory and practical or clinical examination only after the acceptance of the thesis by the examiners. So this is the importance that is given by the NMC for the thesis. And of course, it also says, as part of the logbook, basically it is the duty of the department, the specialty, to assess the thesis or the research work for a postgraduate periodically, and a sort of scoring is also provided by the NMC. So these are the National Medical Council guidelines with respect to the dissertations. Now, assume that the PGs have joined. For example, you have got one more batch ready to come in the next 1 month, and we have got a batch about a year ago maximum. Normally, a circular is received from the university that thesis has to be submitted between such and such a date with all the deadlines. It is routed through the principal or the dean of the college to the head of the department, and the head of the department would share it with the rest of the faculty and postgraduates, and would want the guides to be allotted to all the postgraduates based on the available number of guides. Next, what? So this is a broad outline which I have given. So normally what would happen is the PGs are asked to search for certain topics and submit a list of topics. Okay, so he or she is expected to prepare a list, and the guide would go through this, and he will tweak his requirements sometimes, or he will reduce the list also, and he will finalize the topic generally, or sometimes the guide also has got certain requirements, mainly based on his interest and his knowledge. He will also say, let us pick up a separate topic like this. So this is the way the system runs normally. And it's also possible that the thesis topic that is collected is also discussed in the departmental scientific review committee or the teaching committee, which could be present in the different institutions, either as a formal body or a part of an informal discussion. So before I start, so now we'll go to the main part of how to choose a thesis for dissertation. One thing I want to stress in the beginning itself is using previous dissertations or other published researches per se in toto. So I am highlighting in toto is totally unacceptable. So this was the habit in the previous years. I do agree there were problems with respect to the literature search and everything, but in the modern world, internet technology is available. It's not advisable to pick up a topic and implement the methodology totally and go ahead with the research topic for the dissertation. So the second part related to the how to choose the research topic for the dissertation, I will split it into 2 parts. The first part will be purely about how we can search for the various types of dissertation topics for the postgraduate. Mainly to see that what are the existing knowledge gaps in the resources, and try to make a list of what can be done in the particular institution. And after collecting all these lists, basically, we have to go to the part 2, where you have to talk about the practical aspects of taking up these topics before we finalize the topic. So first part is about the academic resources, getting the topics for dissertation. So this is a list actually. This is by no means a comprehensive list, but this is the one which covers majority of the research areas in terms of the research topics for the dissertations. For example, abstracts of the scientific papers published in the societal journals in the specialty would be an important source. Clinical trial registries in the specialty would be a second important source. Third one would be the university repository of the previous dissertations and the synopsis that is submitted. Number 4 would be the research papers in the national and international journals. So broadly, these would be the 4 areas where we can check for the various topics. Many of us remember that in our previous conferences, 5, 10, 15 or 20 years ago and more, all the papers which are presented in the national conferences, we used to get a printed supplement where there will be all the abstracts which are printed. So we will bring it home to the department and keep it in the department. We will try to pick up some topics there ourselves for our own research, or we'll get the PGs to go through it so that we can pick up some interesting topic which is suitable for that particular department. But now we have gone a little bit beyond that. We have got, for example, Indian Journal of Anaesthesia. So it was in about 2014, in the Indian Journal of Anaesthesia, when I was editor, we published the prize papers in our particular issue of Indian Journal of Anaesthesia. But after some years of struggle, ultimately we were able to publish the abstracts of papers presented during ISACON 2019 as a separate supplement of Indian Journal of Anaesthesia. So as a separate supplement is very important because it is available for us to see online every time, everywhere, so that even people from across the world can see. And subsequently, we had a second publication post the COVID season. It was also published in 2022. So this will act as very important search areas for us. So for example, you go to these particular issues, supplemental issues. So we've got the different types of categories. We have got airway related ones, pain related ones, obstetric anesthesia, pediatric anesthesia, cardiac anesthesia, neuro anesthesia. In fact, we have so many papers in the national conference. We decided to publish only the finalists. Like there will be 10 people in each of the finals in each of the specialties. So we will have all the good papers also which are available here. So you can go through it. When you go there, basically, see, you can get the abstracts of the different papers that are presented. So you have got the background, aims, methods. See, you can have the results and the final part is basically some sort of conclusion which is available. So advantage is you can check that this is published in such and such an institute also, and we can try to contact them. And sometimes you will also get some important illustrations. So I will advise the postgraduates to use this opportunity, I mean this type of option, to try to find out the best topic for them. The next best in terms of chronology only, because the anesthesiology has been publishing the papers presented in the ASA conferences for last almost 30 to 40 years. There is an archive which is available in online. So for example, from 2021, 20, 19, 18, 2017, you can go back in time and you can click all of them as is necessary. So for example, I clicked on 2021 abstract topics, and again I got different specialties: ambulatory anesthesia, chronic cancer, chronic and cancer pain, clinical circulation, and even equipment monitoring and engineering technology. See, this last one should interest us a lot because I don't think we are doing too much of thesis or dissertation of topics related to equipment monitoring and engineering technology. So you can visit this, click open the link and try to see whether an interesting article is available in this particular subspecialty. So if I just click randomly, see, we have got certain types of abstracts which are available, and you can see the full details. So just when I was doing this preparation about 1 or 2 days ago, I came up across this topic. Look at this topic heading: impact of post-anesthesia position on post-spinal variables in elective cesarean section. Okay, so the topic definitely looks interesting. It is very simple topic. There is spinal anesthesia which has been given, then the patients are followed up in the post-anesthesia period, and the patient is positioned, I think, in left lateral or right lateral position, and they are trying to find out the hemodynamics. So that's a very simple topic, and some of these topics are the ones which are innovative, and definitely they are implementable in our setups. So they monitored about 5 hemodynamic parameters. Of course, they also had the cardiac parameters like cardiac output, stroke volume, and systolic and diastolic blood pressure. So, but we may also decide based upon our setup also and try to see what happens in our particular setup. And they also gave a trend and the different types of values in both the positions. And they, for example, said the right lateral decubitus position appears to increase both cardiac output, stroke volume, and SVR. But they said in terms of systolic blood pressure, diastolic blood pressure, and heart rate, there was not much of a difference in the left lateral, right lateral position. So what I'm trying to stress is, don't worry and don't think that some of the foreign publications are too high funda in terms of what we can do or we should not do. There are very simple topics which can be picked up for a dissertation. Similarly, one more source is Anaesthesia, which publishes abstracts of the conferences of Association of Anesthetists. We'll have all the past abstracts, and you can also go through the list here. So we have got different types of articles, multiple types of articles. So everybody has got their own knowledge, and we can also pick up some knowledge. It's not wrong. And look at the final topic, audit on the instance of accidental dural puncture on the maternity unit and potential risk factors. So very simple. So these are some of the things which we are not able to take up or not seen frequently. I will touch upon this later also. Clinical trial registries. So many of our colleagues know about clinical trial registry, but it is not also not known to many of our colleagues across the country. In fact, many of the journals, whenever you go for publication, they will say that we have to register our trials in the Clinical Trial Registry of India. Okay, so this is mandatory, especially for randomized control trials. So what is this clinical trials registry? So all of us who are doing a research, either as a PG or otherwise, they have to be registered. So we can go to the clinical trials registry, create a username and password, and register. So like you, there will be hundreds and thousands of people who have registered their topic with all the details step by step. And what you can do is you can go into this website, search suitably. For example, I have typed as dexmedetomidine. Very simply, I have typed. There is more advanced search which is available, but I have just typed dexmedetomidine as part of the scientific title of the study, and look what I am getting. So I am getting about 970 results, basically 917 results related to dexmedetomidine being registered in Clinical Trials Registry of India, and there are different types of studies using dexmedetomidine, and from different hospitals from across the country. So what is the advantage here? For example, I have picked up one of them. So it will give me full details of the project in the form of a summary or synopsis. For example, this is about a clinical study to find whether dexmedetomidine provides adequate comfort to patients during awake nasal fiber optic intubation. So they have got the contributor's name, authors or investigator's name, okay, their address, their mobile number, the email ID. Very simple reason for this is there are other important criteria why this is given. But if you as an investigator would want to know, I have got some doubts about some topic like this, you can directly contact the author who is going to take up this project also. So what do I get when I go further in this? I'm going to get, for example, the inclusion criteria, the exclusion criteria, specifically the age group, everything is available. And I also get the primary outcomes in that study, the secondary outcomes in that study, the time points for that particular study, then the type of allocation concealment, randomization, everything is given clearly and in terms of blinding also. And more important is, for example, they are given the details of the procedure, how you do the procedure for awake nasal intubation, how they administer the drug, what type of fiber optic scope is used, and what are the complications they anticipate and what they do, and the scoring system they use. So it is like a one-stop option for us to get all the details. They are written about nasal intubation score, post-intubation score, area obstruction score. Okay, all these details are available with respect to the particular topic. So I will strongly advise our colleagues advising the PGs to go to these websites so that they can pick up very useful topics for their registry. For example, I have some entries. I just typed my name as an investigator only. So I got about 8 results. So 8 of the researches where my name is also included, they are displayed here. What we can do is you can click open on this and see the whole protocol for that particular research apart from the title. So you can pick up a title and you can check the protocol also. This is the advantage of going to the Clinical Trials Registry of India. So registries are there across the world. In fact, it's also based upon it's a WHO project. So biggest registry out of about I think not more than 15 registries are there in the world. The biggest one is from United States of America. So it has got the entries from 221 countries apart from USA, and there are 422,000, more than 4.2 lakhs of research studies which are registered in this particular website. This is clinicaltrials.gov. this is a website I would want all the PGs to remember and use it liberally at any point of time for their own interest. Again, what I did, I just entered IGEL here as a brief search item. Look what I got at about 94 studies related to IGEL, right? And we can also use some filters, okay, in terms of different criteria, the age, the type of the procedure, the type of anesthesia, and in terms of stages of implementation, whether they are just registered or the thesis work is going on or the research work is going on, whether it is completed, whether it is terminated, all the details will be available. Look here, we have got some completed projects on the left side. So comparison of IGEL, laryngeal mask airway, placement methods in elective surgery, application of IGEL laryngeal mask airway in pediatric patients, IGEL versus AirQLM in pediatric patients. So these are from different parts of the world. So what you can always do is, as I said, filter out, use various types of filters in terms of study type, results, and case and other things. And you can get further details of the particular project. Okay. So I picked up one of these articles of IGEL versus LMA supreme in laparoscopic gynec surgery. What you will get is all the details just like what I showed you in CTRA. So it shows the design of the study, it shows the group allotment, it shows the procedure that is taken up, and all the details. So because of lack of time, I will not go into the details, but I advise you to pick up these clinical trials agencies as an important source. And of course, you can go to the repository of your own health university. Health university. And in health university, we'll have the data of the previous dissertations done in the colleges under that particular health university. So what you can always do is so even the medical college name is given, and you can try to reach out to these particular investigators with respect to their methodology or the shortcomings in their research, what they expect in the future research. All those things can be assessed when we go through this resource. And if you think specifically about the contemporary topic, so contemporary topics will be available in, of course, in the clinical trials registries. Definitely, it will be available, and it could also be available in many of the conference proceedings. But to make doubly sure that you are picking up the right topic, you can go to the journals. Okay, you pick up the recent journals of the specialty. You can go to Indian Journal of Anesthesia. You can go to JOACP. You can go to British Journal of Anesthesia. You can go to Anesthesia Analgesia. And you can go to anesthesiology. So don't think that I'm citing some of the bigger foreign journals also. Advantage is many of the articles are now also provided free, especially in the last 7-8 years, when the open access has become more dominant, and you can pick up suitable articles. Then Canadian Journal of Anesthesia and Regional Anesthesia and Pain Medicine Journal, if you want to pick up something related to specialties. And you can have those related to cardiac anesthesia, neuro anesthesia. So many journals are available. And pediatric anesthesia, for example, okay, specific to pediatric anesthesia patients. Then you have got Journal of Obstetric Anesthesia and Critical Care, an Indian publication. It's also a very good journal. Then you have got International Journal of Obstetric Anesthesia. So advantage is when you go there, again, you can find out that the list or the table of contents of the articles published in different issues. At least if you look at the table of contents, you'll get an idea that such and such articles are published, and this could be suitable for my institution. So that's how we take it forward. For example, all of us know phenylephrine 50 mics per ml preparation has been released briefly. Just about, I think 2 months ago, it has been released into the market. So far, we had an ampule, I think about 10 milligram of phenylephrine, 1 ml ampule, and it was difficult for us to use as routinely for spinal anesthesia prevention of hypotension. But we had a launch of phenylephrine 50 mics per ml solution recently. So what would happen is it will give us an idea, yes, why don't we use it more frequently? But do I use it for prevention of hypotension or treatment of hypotension? No. What we can do is, for example, this is a recent article in May, which is published, and it talks about effect of low-dose phenylephrine infusion on shivering and hypothermia in patients undergoing cesarean section under spinal anesthesia. Okay, so it's not talking about the hypotension aspect at all. It is talking about shivering and its control. So we can find basically, of course, it's a new article. If you at least look at the abstract, you'll get the methods. What they have done, they are given 25 microgram per minute of phenylephrine infusion, started immediately after initiation of spinal anesthesia. and continued throughout the intraoperative period. In the other group, they did not give phenylephrine, it was just a saline. So what they tried to find out was the incidence of shivering in the two groups. They found that the incidence of shivering in the patients given phenylephrine was around 24%, and it was more than double in the patients not given phenylephrine. And of course, they compared the hypertension risk and then bradycardia, hypertension, everything. Obviously, in the patients given phenylephrine, the incidence of hypotension was also less. So what I was trying to convey to you is that there is some sort of novelty when you look into the contemporary topics. And topics like this are definitely implementable in our setups. So we again need not talk about something which is not possible at our centers. And another one which was present in anesthesia. So for example, many of the places now the carbitocin is being used to reduce the uterine bleeding after cesarean section. Especially it is said it is good in controlling the risk of BPH, and a single dose is enough as compared to an oxytocin infusion. So this was a study which was published in March 22. They compared carbitocin versus oxytocin in elective cesarean delivery, a double-blind randomized controlled non-inferiority trial of low and high dose regimes. This title is also very nice and attractive, but again, I will not go into the details here because it is good in terms of the design that is being mentioned. So what they did, if you look at the methods, they picked up carbitocin at a normal regular dose of 100 mg, but they used a low dose of 20 micrograms. Then oxytocin 0.5 units bolus followed by infusion, and oxytocin 5 units bolus followed by infusion. So these were the four groups basically. And very surprisingly, of course, the primary outcome was the uterine tone 2 minutes after the study ended basically. They said there was carbitocin 20 microgram was good and as comparable to carbitocin 100 micrograms, and 0.5 bolus and 5 bolus of oxytocin followed by infusion were also non-inferior. So basically, there was not much difference. So this is a useful study. I'm not going to the technical, theoretical discussion here. So what I would like to convey is this is a contemporary topic which can be implemented, and we are this. For example, I got it from a recent publication from the International Obstetric Anesthesia Journal. So one more way we pick up the topics could be from our own peers. For example, when I say peers, it could be the PGs themselves. So PGs, for example, they are admitted, the same batch people are there in other parts of the country. They can directly discuss amongst themselves. Or guides, for example, even if I have doubt, I will discuss with Dr. Sudesh, I will discuss with Rakesh, or I can also discuss with Dr. Edward. So it's a matter of exchange of academics, and we can say this is a good title, this can be implemented, this is can be taken forward, or this is not good, or we may be forced to stop in between. So these are the ways we also discuss and decide on picking up the nice topics for the research. So overall, if you think that I got a huge list obtained from the postgraduate, a postgraduate comes and gives me the big list as per my advice, and I go through it and try to finalize certain list of topics, shortlist it, and then go to a final topic. Okay. So is it possible for me to finalize? No, it's not. Straight away, it's not possible because it should be practically implementable in my particular medical college or the setup. So this is the part 2 of my presentation now. Basically, what you have to keep in mind is a mnemonic by name FINER, FINER. So that decides on whether we can implement that particular topic and take it as a final topic for the thesis. So what is this FINER? F is for feasibility of that particular research topic. I is for interesting. N is for novel or novelty. E is for ethical considerations, or is for relevant. Okay, I got a list. I got everything done, but I should see that whether it fulfills the FINER criteria for practical implementation of the project. First, feasibility. Simple definition is that it represents the ability of the investigator or the postgraduate with the guide to carry out the research project in the particular medical setup. For example, it could be related to the patient or the samples themselves. In terms of the availability of the surgical patients, whether it's related to an intensive care, acute or chronic pain, or some cardiac anesthesia or pediatric anesthesia group, elderly patient. So this is with respect to the feasibility, whether their patients are available. And human resources. So basically, if you are talking about a postgraduate and it's a busy medical college, and OT is very busy. So whether the PG is able to get an assistance, even PG cannot do alone. So you have to have pre-anesthetic evaluation, pre-operative advice, intraoperative management, and you need a post-operative follow-up also. So in that regard, you may want another PG to help out, or you may want a trained nurse to help out, especially in the post-operative period. So many of us have seen, for example, we do normally analgesia-related cases. We will advise that no analgesic shall be given in the post-operative period till, for example, the patient complains of pain, or, for example, the numeric rating scale reaches about 4 or something like that. So sometimes what happens, this doesn't happen, and sister would have given the analgesic, and you lose that particular sample. So this is the way. So we have to always check that adequate number of human resources in terms of our own colleagues, our guides, and the nursing staff are also available. And resources in terms of the devices. Okay. So if I want to pick up a topic which involves ultrasound, that must be available, and that must be available to use by me whenever there are cases. Should not be in lock and key, or it is used sparingly, or I would want certain testing, laboratory testing to be done before you take up the test. For example, I would want the if I use etomidate as an induction agent, or use it in a major procedure, I may want, for example, serum cortisol to be done, whether it is possible to get it done in an institution. So these are some of the things which we must decide beforehand. You start and then you get lost. So that's a problem sometimes. So that's also the one which influences the picking up of the article or the topic. And finally, funding also. Yes, it's very important. Even now, dexmedetomidine is a very costly drug. So if I'm going to use dexmedetomidine as an infusion, or I'm going to use it in a bigger sample, so we should always ensure that it is available in the pharmacy. And if it is not available, what is the scope for continuing the research project? So these are some of the examples. So this is with respect to the feasibility of this study. So as I told already, that depends upon the different specialties we got: pediatric, obstetric, cardiac, neuro, airway related, and everything. But overall, what we do discuss in terms of general anesthesia, central neurological blockade, regional anesthesia, or we can have monitored anesthesia care. So related topics could be general anesthesia means definitely it is something related to airway, then intubation responses, use of IV agents, inhalation agents, then we have got relaxants, reversal agents, intraop analgesia. Then you got the central neuraxial blocks, where we basically talk about vasopressors. I just talked about using phenylephrine and other use of fluids, local anesthetics and sedatives. And regional anesthesia, of course, nowadays we are more and more talking about ultrasound usage and the drugs which are available. And monitored anesthesia care, the various types of monitoring, which is important in monitored anesthesia care, and the location. For example, non-operative room anesthesia or outside of the OT. So we can have ICU where we can do a research. We can have PSCU, or you can have pain clinic related research that is taken forward. For example, if it is non-operating room anesthesia, as I said, we can have monitored anesthesia care related topics. We can have airway related topics where we don't want to intubate. We use a supraglottic airway devices. We talk about TIVA, total intravenous anesthesia, or we talk very frequently nowadays about dexmedetomidine used for every case and everywhere. And discharge criteria. Okay, because majority of them are daycare procedures. You admit the patient and discharge the patient. So these are some of the concepts related to which we can pick up the article topic for the thesis. Then ICU, definitely majority of into ICU, we know ventilation related topics can be chosen. Sepsis and other things can be chosen. PSCU, normally we are basically trying to target acute pain, discharge criteria, the oxidation status, hemodynamic status, right? The patient is just shifted. So main aim is to see that patient recovers from the anesthetic effects, then the patient is shifted to the wards or a step-down unit. And generally the follow-up is very short in PSCU. So this is also an advantage when we think in terms of feasibility. Okay, so if it is available, PSCU is available, short stay is available, where we want the nurses to follow up the patient, as I said, about the availability of human resources, we can pick up a topic related to PSCU. Pain clinic, if you've got pain clinics available, especially chronic pain, for example, follow-up is secured for a long time. So this is one of the limitations, but again, if you've got human resources and time, we can always talk about this. But this time duration actually is a problem, because we are talking about the postgraduates learning to understand the research methodology, and it should not affect in the routine management of routine duties of the postgraduates. Okay, and they have to read and do other things also. So that way, it is advisable to see that the follow-up duration should be as minimal as possible. So only those research topics where follow-up requirement could be less would ideally be advised. And this is my opinion. But if the facilities allow, definitely we can take up those subjects where follow-up could be for longer time. So with respect to the fields, as I said, the GA and ICU and everything, I talked about ICU topics which can be picked up. I said about the PACU, pain clinic. Less attempted, what I find is those which are related to the preoperative period. So something related to preoperative fasting and feeding has gained momentum now because we have got ultrasound, which is being used everywhere, gastric ultrasound. But otherwise, something related to pre-medication, not many topics are being picked up. Preparation of the patient in the preoperative period, not much has been talked about. Much of it is talked about with respect to a major procedure, the cardiac surgeries, then open heart procedures, or for example, those major colorectal procedures where we talk about ERAS and all. There the preparation is talked about much, but we can also talk about preparation for routine anesthesia procedures. Why should not do in an elderly patient? Why should not do something in an obese patient for non-bariatric surgeries? So these are some of the things which we should come to our mind. And prehabilitation. Can we promote the 6-minute walk test also, plus follow up with breathing exercise, so that we check the ambulation in the post-operative period and see that the adverse events come down in the post-operative period also. And the post-operative related, so normally we talk about analgesia, PONV and hemodynamics, but can we do better? So we can always talk about, for example, how many of us have checked about the sedation and the expert permanence in the post-operative period? We have not done much thesis about the neuromuscular recovery, then amnesia part, the fluid status in the post-operative period, resumption of the oral intake, because we are mainly focused upon analgesia and other things, but we also, I think these are some of the ideas which come to my mind. So many of our guides and our colleagues across the country would know that there are many things which we can do in the post-operative period also. I do agree that post-operative period assessment would depend upon the human resources, which I spoke about in 2-3 slides ago, and also the dedicated time which we need. But whenever the facilities are available and interest is there, if there is an interest, definitely we can implement some of the topics related to the post-operative period in the anesthesia setup. But of course, the most important part of feasibility is the skill of the investigator. So postgraduate, you are given some topic to the postgraduate. And the postgraduate almost everywhere has got certain limitation because they have just completed MBBS, they have joined the course of MD anesthesiology, and they are within the first 6 months of exposure to anesthesia. So whatever the topic is chosen, so that should be commensurate with the skill of the postgraduate. So we cannot be giving an extraordinary investigation, the title to the postgraduate to take it forward, and a PG is not able to do, and sometimes the guide is also not able to do. He has picked up a new topic, he is not trained enough, and that will affect the implementation of the research topic. So what is advised therefore is either the faculty himself attends to some research workshops or the particular workshop, or they can invite an expert to the institution, see that all of them get used to the system, then implement the research topic for the postgraduate. So apart from feasibility, which is very important, as I said, it should be interesting. I is for interesting in the mnemonic. It should be the topic that is chosen should be interesting to the investigator. When I say investigator, it is the postgraduate and the guide. Number 2, it should be interesting to the patient. Why I am talking about the patient? Because when you discuss with the patient that you are going to be part of my study, you are going to give all the information about the particular study, then get an informed and written consent. This is called information and get a written consent. So if the patient is interested, if it is interesting for him, it's okay. If he is not interested, he will say he will not accept. So whatever is chosen should be interesting to the patient and it should be interesting to the hospital also. Okay. So majority of the times it is not an issue, But basically, in the overall picture of the available facilities and the anticipations from the hospital administration, it should be important. And to the funders. Okay, so funding, if you are indeed getting a funding, normally the funding system is not that much widespread in the Indian medical scenario, but it is more in the Western countries. So the funders should also be interested when they want to sponsor a particular research topic. So if the investigator, the PG and the guide are interested in the topic, it helps in genuine implementation of the methodology, and hence the results and the outcomes are more acceptable. In fact, you can also publish it. So the quality of your work would definitely improve. If somebody is not interested, can it be that the PG is not interested? Okay, so sometimes all of us as guides may not be thinking about the interest of the postgraduate. So is it possible to talk about the interest of the postgraduate? As I said, they are fresh into the postgraduate scenario. If they had been part of some research in the UG level, in the MBBS, maybe they'll have an idea. And if they have read adequately or know the thesis, the theoretical aspect and the practical aspect of anesthesia in the first few months, maybe we can talk about the interest of the postgraduate. So this is a relative discussion. So, but this is a very important message. If somebody is not interested, is it worthwhile to push him to do that? So in fact, I am the ethics committee member secretary here. A few days ago, what I found was from one of the specialties, two of the thesis topics which were submitted, they said they want to change. And both the instances, the guide said that the students are not interested. So I'll not go to the details of why they were not interested, but in the context of involving the PGs clearly and their interests, I'm raising this particular point. Next part of this mnemonic finder is novel or novelty. When I talk about novel or novelty, this is a relative requirement for dissertation. Let me stress again, novelty per se is not too important in a research as part of dissertation for a postgraduate. Basically, because it is acceptable to use the ideas and methodologies broadly, which you have seen in other studies also. It's not a problem, because NMC only wants you to understand the basics of research methodology and become a researcher possibly in the future. Okay, so that is the one with respect to the novelty. But at the other end, definitely it is never advisable to copy paste all the methodology and ideas of somebody and try to implement it, which I had put up in a slide already. So it is definitely not advisable. But ensure some sort of novelty with proper application of knowledge. Of course, here the guides have got an important role to play. So what is novelty? Novelty is one which is an idea which is not repetitive, not likely to result in new outcomes, or confirming or refuting an already well-established finding. So everybody knows that something is done. Okay, so when I say, for example, regional anesthesia is very good for a patient with COPD, it's a proven thing. And if I go further, I will say I'll give something like an epidural anesthesia for a procedure which is lasting for 3 hours. It's a well-proven technique. So trying to say something which is well-established, well-accepted across the world for last few decades, it's not acceptable and taken up as a novel thing. For example, if I get an airway response attenuation study, even now if somebody does, I'm going to compare lignocaine with a beta blocker. It's not acceptable. Somebody says I'm going to use bupivacaine with buprenorphine for brachial plexus block, supraclavicular, and say I will compare it with bupivacaine alone. It's definitely not novel. And predictors of difficult airway. I find a lot of articles and researches as part of dissertations with predictors of difficult airway. So not to again comment against the opinion of some of our guides, but broadly, it is required that some sort of novelty is allowed in the thesis topics also. So what we should be aiming is establish new facts, and if it is not possible, finding a new aspect of the established facts. And it should show some imagination on the part of the researcher. Okay. So overall, the research question which we pick up must be simple and clear. And again, I have got some opinion here. Basically, in terms of novelty, we are not attending trying to provide some sort of topics out of the routine. For example, can we think about simulation studies and volunteer studies? And can we do some sort of observation studies where it is suitable? Crossover studies, case control studies, cohort studies, some sort of surveys and audits. They've got their own limitations, but you can always think about them. Then retrospective studies. So these are the ones which can always come to our mind. So typically talking again about, as I said, spinal anesthesia, then analgesia in the postoperative period, then epidural, then some sort of block or intubation responses, or using a different types of supraglottic airway devices. So these are the ones which are already practiced everywhere. But we can also expand our horizon of research without disturbing the postgraduates at a basic level. Retrospective studies, it's reviewing the already collected data. This is the one which can pick up also. So what is the advantage of performing a retrospective study? There are three advantages. One thing is it provides the data that may be lacking for that particular research question, specific for the department, specialty, hospital, or the government setup. For example, in my institution, I will want to know if I don't have a data, I will want to know about the number of the pediatric anesthesia cases being done. Okay. Yes, it is there in terms of gradually. So when we collect, this is the pediatric anesthesia department, 10 cases, 5 cases, like that. But I don't have a specific breakup. Nobody has attempted to do it. So what I will do, I will go back to the MRD and pick up all the data. So what I will get, I'll get the age-wise breakup of the pediatric anesthesia patients, then different types of surgeries, then you have different types of anesthesia, and the different types of possible adverse events that has happened in these patients. So that is the data I am going to build up. This data will be useful subsequently for somebody to take it forward for a future research. And third one is subsequently, a study like this, retrospective study, will take lesser time to match the short stay in the institution, because I said PGs are there for only 3 years, and you cannot be pushing them to do all the cases for all the 3 years of time or even the 2 years of time. So a study like this will take less time, but its utility is also good. Then something about the case control. I want to sensitize you, the postgraduates mainly, a case control study. Case control study is normally, for example, retrospective study. So where we have a certain set of patients with outcomes. So one set of patients with outcomes which has already occurred, and it has not occurred in another group. So what you do, you go back in time. So find out one patient, one of the group has been exposed to the risk, and they have developed the outcome, and another group of patients are there who are matched in terms of age and the pathology and everything. They are not exposed and they may still get the outcomes. So this is something called a case control study. Just to make you understand, it's not too exhaustive. For example, outcome could be uterine bleeding. So you find that in the post-operative period, post-cesarean section patient, there is uterine bleeding. So there are two groups. So what you try to do is you go back in time and try to see that there is a group where tranexamic acid also been administered. This is hypothetical. Please don't take it otherwise. One group of patients have been given tranexamic acid, and another group has been given no tranexamic acid. Okay, and both of them had prolonged labor, but uterine bleeding occurred only in some patients. What you try to do is how many of the patients in tranexamic acid had uterine bleeding or not, and how many of the control group had uterine bleeding or no uterine bleeding as compared to the tranexamic acid group. This is something like a case control study. Or we can have quad studies. Okay, it is prospective generally. For example, we have got a group of patients who are exposed to a risk. It is called a risk. Risk could be a drug which has been given, a vaccine that has been given, or a surgery that has been done. Okay, some event that has occurred. And this is a passive one. This is not an intervention. Group 2 is not exposed and it is matched. You follow up in time. So those who is exposed to a particular drug or risk or technique, they may develop an outcome, they may not develop an outcome. Those who are not exposed also, they may develop an outcome and they may not develop an outcome. For example, you can have all the pediatric patients admit to the PSU, okay, in the post-anesthesia care unit. So what you can do is just observe. You are not doing anything. You try to find out the history of allergy, atopy, or wheeze in the patients, in the pediatric patients. So there could be one set of about 20 patients, or one about 6 months, who have history of allergy, atopy, and wheeze. Okay, then try to follow. So these patients may have intra and post-operative respiratory episodes, and we have got another group which doesn't have an history, but they also develop some intra and post-operative respiratory episodes. Okay, so this is called a cohort study. So something like this can also be done very easily in our setups. Then audits. Okay, there is still possibility. Even the university is not clear about this, but I definitely feel audits are also very scientific. We can also do it. It's a type of research. It is a method of comparing what is actually happening in clinical practice against agreed standards or guidelines. Okay, for example, we are all expected to do a machine check and equipment preparation before you enter the OT or start a case or everyday model. Something has to be done every day, something has to be done before every surgery, and something has to be done on a weekly basis. So is it implemented, or the guidelines are implemented in your institution? Then clinical audit on the quality of prognostic evaluation. So what should be done in the prognostic evaluation? There are set standards. So when the PGs read the Miller, they'll get the full list. But is it being implemented in the medical college? Or if it is implemented, to what extent, right? Similarly, perioperative fluid management. So all of us talk about the preoperative fasting, and we have the need to have some maintenance fluid going to the patient. But is it followed in a particular institution? So what are the problems? And advantage of audit is we can always advise the administrators, and the department itself can take action to see that the things improve. And for example, a clinical audit, it's a very nice topic. A clinical audit on cancellation of elective surgery on a scheduled day in a teaching institution. So very methodologically, they have discussed why there were possible problems, where was the missing link in terms of guidelines not being followed, and how it should be improved. So this is something related to the audits. Then going further with finer, the next one is in the mnemonic is ethical. So whatever we do, yes, this is taken for granted. We must follow it. We must submit all our required topic in the form of a synopsis or a research proposal to the Institutional Ethics Committee. The Institutional Ethics Committee works under the ICMR guidelines. Okay, all of us know ethics basically represents the following the regulations of the institutional, national, and global level advisors, and we are to protect the privacy, confidentiality, and right to withdraw the patient. And another important component of even the research proposal or synopsis is we have to mention the sample size. This also has got ethical consideration, because when we need a statistically calculated sample size, that is the one which is enough to have a statistical reliance in terms of the outcomes. So if you have something which is which says that I need 35 patients in one group and 35 patients in another group, and if I do unnecessarily in 50 patients and 60 patients, okay, it is said to be ethically incorrect also. Okay, so this is the advantage, the importance of talking about ethical aspects apart from everything else. If we don't follow the ethics committee requirements, especially, and if your synopsis is not prepared properly, you are definitely going to get some important critical comments from the ethics committee or from the university also, or sometimes it could be rejected. So problem is there could be delay and you will get into stress. So this is mainly addressed to the postgraduates. So final part of this finer mnemonic in terms of practicality or implementability of the thesis topic is the relevance of the topic. Okay, relevance is it relevant to your area, your department, your patients, your knowledge? Okay, or whether it is useful to be taken up so that there can be scope for future research also. Okay, so anticipated outcome should be relevant to practice, and it should be as contemporary as possible. It means you do something. So I conduct a study. I say I add a drug X into the supraclavicular brachial plexus block by ultrasound guidance. So when I use this drug, I find that it is going to work for 30% longer duration of time as compared to, for example, dexamethasone. Okay, so if something like that happens and you implement the study scientifically and you publish it also, once it is published, all the practices, the new drug, you should be able to use regularly in your own institution. And people who have read your article also should be able to follow on that particular outcomes. So this is the relevance. So I do something and it is forgotten. Of course, this is the way it happens in majority of institutions nowadays. Relevance in terms of applicability in the institution doesn't happen. Everybody completes his thesis. A lot of hard copies are present in the department. Nowadays, hard copies are also not allowed. Soft copies are there, and it is just forgotten. Okay, even me, if I am the researcher, if I have done a research, at least I should implement that outcome and that practice in my future. If I become a freelance anesthesiologist or join some institution, I should be convinced that I have done a very committed work and the outcomes are good. I will implement in my practice. Okay, and that's what I have mentioned here. It is implementable in your hospital or the setup. And sometimes we can talk about some topics related to the public health. Okay, it can be the source for topic for dissertation sometimes, because this will also add data to the government and for creating of health policies. So, if, for example, all of us have heard about tuberculosis, HIV, dengue, or all public health problems. Government at the local level and state and national level is very much interested. But all of us, it is fresh in our memory. COVID-19. All of us were involved in COVID management, and all of us know, and majority of us were able to still find time to do some research work with respect to the management of the patient, oxygenation, ventilation, ERDS, sepsis, antibiotics, anticoagulants, monitoring, investigation. So there have been hundreds of publications related to COVID-19. Similarly, where could be the scope for us with relation to the government policies? So anesthesiologists, we can have something related to trauma, emergency care and CPR, onco-anesthesia and palliative care. So these could be the focus areas for some other topics. So beyond this finer criteria, feasibility, interesting, novelty, ethical considerations and relevance, there could be 2-3 small considerations. The role of a pilot study. This is just to complete the presentation basically. Many of us will say, I have picked up this topic, I will try to see, I will do a pilot study, if it is okay, I will take it forward. Just I wanted to convey to the postgraduate, the pilot study is only a feasibility study. It's only used to streamline your methodology. Okay? For example, design, recruitment, randomization, retention, assessment procedures, means how do you do the procedure, new methods and implementation of the novel intervention. Okay? So just for ourselves to get used to the project. Okay? It is not for testing the hypothesis. It is not for evaluation of the safety, efficacy and effectiveness. And it is definitely not to get a meaningful effect size estimate for sample size calculation. Even though many of us, including me, would tend to talk about some sample size based upon pilot study, scientifically it is not advisable because it is not correct. And this is an open-ended slide here. Does geography have a role? Why I am trying to talk about this? Because many of us justify that somebody has done in, for example, I will say it is done in Kanyakumari. I will say I will do it in Ballari. I will say Ballari is a different place. Our people are different. I will do. I will accept it to the extent that I should be able to prove how different my patients are. Okay, so if I say somebody has used, for example, you have got a new drug. I say I got Sugammadex, I can afford. I will use Sugammadex for reversal agent, which is already proven, and I will do in my institution. So if money is available, okay. But if about 100 patients are done in about 100 places in India, and telling that I am doing for the first time in my place, it's not correct. Okay, something purely related to, for example, demography could be. Right. For example, when I say the airway related things, that's somewhat acceptable because all of us have experienced that in some areas, there are some patients, the population has got larger glottic opening. In some areas, there is smaller glottic opening. So these are some of the things, but generally, geography may not have a role. For example, I see people presenting the papers or even the thesis topics telling supraclavicular brachial plexus block under ultrasound guidance at WIMS Ballari, for example. So at such and such institute in this place. So adding that name doesn't convey any meaning. Okay, we should always think about that before you realize the topic also for that particular setup. Multiple researchers from a single topic. This is another contemporary discussion which goes on amongst many of the guides. In the context of the increase in the number of the postgraduate seats across the country. So all of us always say that we don't have enough of material and enough of topics to be distributed. So now I can say enough of topics are there, but enough of material may not be there. Okay, so far what I have discussed is, hopefully I have conveyed that there could be topics which are available with small innovations or modifications. But in terms of material, I do agree that there is a limited number of material. So if such is the case, it's always possible and acceptable based on the input from our academic colleagues from across the country that we can have multiple researchers from a single set of clinical material. So that can always be done. That's not against the rules and ethics. And it's another focus can be about interdepartmental interspecialty research that can also be taken up, so that we also share the requirement of clinical material between two departments, so that good quality is also provided simultaneously with the various topics for the postgraduates. So let me conclude the concluding slide here. So what I started was about the NMC mandate related to the thesis presenting, thesis and dissertation work by the postgraduate. It's very important, and also we agree that it is time bound. And number 3 is very important. Novelty is okay, but now it's a relative requirement for postgraduates, because it is mainly included to inculcate the research methodology practices and the spirit of research in the minds of the postgraduates. So that way, novelty is only a relative term, but within the available literature and the evidences and the facilities, it is always advisable to see that we do some sort of original work, never copy paste. That is my advice. And I have showed the full list of the various options to obtain the topics for the thesis. Most important, definitely, I'll be very happy if people go through the clinicaltrials.gov, the American website. It has got exhaustive number of topics which are available, and they can go to the CTRI, Indian Clinical Trials Registry of India. So that is another stop for us. Third one is the abstracts or the presentations presented in the various national conferences, not just in India, but it could be from the ASA, it could be from Anaesthesia and other sources. And next could be going through the recent journals. So that's another option. And of course, I also talked about the repository in the different health universities where you can pick up. And when you give all this topic and the guide, many of us are guides, when you pick up, we are going to narrow it down to particular 1 or 2 topics. But in this list, we should always check whether it is practicable to do this particular topic in your institution by applying the finer criteria. Okay. So if you deviate from finer criteria, it's always difficult to complete the project. Okay, I said there should be feasibility. Most important is feasibility and relevance, apart from being ethical and interesting. Novelty, I said already, it's a relative requirement basically. And I also talked about some different designs, not always talking about randomized control type, this group and this group, or a single group observation study. Try to talk about some alternative designs. And to end, I will always say it's always important for the guides to take up the work seriously also. Majority of us are doing. It's nothing against anybody, or I don't want to get into some controversy. But I would only like to highlight that the guides are there to supervise or direct the postgraduates. Even if you look at the grammatical definition of what is guide or guideship, it is the ability to supervise or direct. So that's more important. So that's the way you have to take it forward with respect to the postgraduates. So thank you very much, Dr. Edward and the Anaesthesia Online team. Thank you very much. This is the end of my presentation.
Thank you, sir, for wonderful and excellent presentation. This is the big question in the postgraduate when they join the MD Anaesthesia, how to select the topic. So every year, the beginning, I used to get many queries. Sir, suggest any one of topic. So I used to say, you go and search and come with the 3 or 4 topics, then I will select the best one. So you have correctly elaborated where to search these topics and how to go about it. Thank you very much, sir. So we will move on to the next topic, sir. So the next topic is implementing the research methodology by Dr. Sudhis. He is the professor in the Department of Anesthesiology, Bangalore Medical College Research Institute, Bangalore. He is the editor of Karnataka Anaesthesia Journal and ex-associate editor of IJA 2010 to 2021. He is the got the President Appreciation Award of IAC National in the year 2019 and 2021. He had more than 32 publications for his credit. So over to you, sir. Sudhir, sir.
Thank you, Edward, sir. Thank you for your kind words, and good morning to all the delegates who are here. So we had a very beautiful description about how we select a topic by my teacher, Balbhaskar, sir. So now I'll be trying to go through few quick points about how to implement our research. Like now you have decided a topic, you have decided about this one, and now how do you practically implement that to get meaningful outcome of your study? So, wish to bring greetings from Bangalore Medical College, the place where I work. And if you see the types of study design, to start with, there are two types of study designs: the descriptive study or an analytical study. This is in a very broad concept that it has got two types of study. That is a descriptive study where you don't do anything, you just go on observing and just mention the details. Whereas analytical, you try to observe the difference between the intervention and the non-intervention group, or say a test group and the control group, and finally analyze what's going on and try to come to a conclusion. So based on that, if you go through the epidemiological studies or clinical trials can be classified as descriptive and analytical, and when it is involving individual patients, when it's involving individuals, it can be either in the form of case reports, case series, or cross-sectional surveys when more than 20-30 people are involved, or it can be done in a huge population in the form of ecological studies, which generally is not a domain of the anesthesiologist. On the other hand, the analytical studies again can be observational, where you observe a set of people with a risk factor or without a risk factor and see what happens to them, or you observe a set of people who had certain outcome and go back to see what happened to them, what resulted in that particular outcome. So these are case control and cohort studies already described by Balbhaskar sir. And most commonly sought after and most commonly done in anesthesia practice is the interventional trial or clinical trial, which is, in other words, randomized control trials. So basically, this is a very planned experiment where you try to assess the efficacy of a diagnostic or a therapeutic technique or procedure, and of course it involves comparing the outcomes by comparing two groups, that is a test group and the control group, and it is most of the time, 99.9% of the time, it's always a prospective study. So depending upon the type of the thing what an investigator does, suppose if we assign an exposure or if he intervenes, it can be, if it is intervenes, then it becomes an experimental study. And if you follow a sequence called random allocation, which I am going to discuss in the subsequent slides, they are known as randomized control trial. If you don't do that, it is non-randomized control trial. On the other hand, if the investigator doesn't employ any exposures or doesn't do any interventions, he just observes a set of patients, then it is known as observational study. If there are two groups within the observational, there are two observational groups and you are analyzing them, depending upon the direction you go, whether you go from exposure to outcome or outcome to exposure, they are classified as cohort and case control studies respectively. And if you are try to study the exposure and the outcome at the same time, we call it cross-sectional studies. This is what we are most of the time trying to do in our anesthesia practice. Commonly, as Balbhaskar sir described, certain examples would include airway assessment parameters, studying the incidence of PONV in a particular type of anesthesia practice, or it can be a set of investigations which you are trying to see, and you are seeing how they affect your anesthetic outcome. So depending upon the type of question, already this has been dealt with in the earlier studies, but still I'll just touch upon. If you want to try assess the burden of illness or prevalence, for example, incidence of difficult airway, incidence of post-operative nausea vomiting, incidence of nerve injuries following a regional technique, you go for cross-sectional study or a longitudinal or field service. In case you are trying to assess causation risk, suppose you are trying to assess the effect of a particular risk factor on the occurrence of an outcome, you go for either case control or cohort study or even RCT. But if you are using a treatment, diagnostic study, or cost effectiveness, most of the time what we use is randomized control study, which is the common type of study which is practiced by anesthesia fraternity. Though most of the recent, as Balbhaskar sir was highlighting, I think we need to move on from there and try to find, there are a lot of areas where we can do cross-sectional surveys, and definitely that can be used as a study design also. So once you decide the study, you always decide like based on the final criteria. Already this has been discussed with Balbhaskar sir, and you generate a research question. Now again, what do you mean by a research question? Research question is it's not the title. Please take it from me. research question and title are not the same. It's not necessary that they have to be the same. It's just that the title will reflect the research question, but it's not always necessary that the title and research question has to be same in verbatim. I mean, the same words should not be there. It's not necessary that the same words should be there in both research question as well as the title. So basically, we generate a research question. You generate based on a criteria known as Picot criteria. Now, what is this? One is you define the study population in the research question, and then next you mention what is the specific intervention you are going to do. Now, study population, for example, when I talk about study population, it's about, for example, you're doing a study on effect of intrathecal buprenorphine on post-op analgesia in intrathecal buprenorphine. So your study population automatically will be the patients who are receiving spinal anesthesia. Simple, isn't it? So you clearly define what is the study population, and then next, what is the intervention? Intervention here will be addition of buprenorphine into intrathecal space. So that is the intervention. It's not the spinal, it's the addition of buprenorphine. So intervention can be the drug, or it can be a technique, or it can be a introduction of a new method or introduction of a new device. Anything which you are using to test against the standard of care will become an intervention. And finally, the control. Control specifically mentions against whom you are comparing the test drug. Most of the time, either you can compare it with the standard of care. The use of placebo here is a little controversial, and it is better to avoid use of a placebo against test drug. It's always better to compare the standard of care with the test drug. And next, you have to clearly define what outcome measures you are going to follow. You should be very clear. In case now in the previous example, as I stated, we are talking about the presence of in administration of intrathecal buprenorphine on post-operative analgesia. So post-operative analgesia is a broad term. It's a broad outcome. Among them, you have to specify. It has to be very clear. Like there has to be one primary objective which will be specific, and other things can be secondary objective. For example, whenever we talk about post-operative analgesia, it can be duration of post-operative analgesia. It can be the quality of pain relief, which can be subjectively measured by VAS scores, or it can be the number of analgesics that is required in the 24-hour period, or it might not be only the positive aspects, also the negative aspects. For example, we know whenever we add buprenorphine into the intrathecal space, it can result in post-operative nausea, vomiting, and post-operative respiratory depression. So you can also study that also as one of the outcomes. So, but the thing is, all these things, whatever I mentioned here, has to be depicted in your title very clearly, or the study research question very clearly. So based on these parameters, now generally we prepare a synopsis to be submitted to the university or to the college authorities, to the institutional ethical committee first. From there, it goes to the university once it is cleared. So generally, it consists of some of the important things like your introductory parameters, like whatever name, your institution, your subject, the title, etc. And then a next important thing is the objective of the study, which has to be very clear. So you have already decided upon a particular objective. Then based on that objective, you will describe in the materials and methods section, like what is the source of data and how are you going to collect that data, and what during what period you are going to collect that data, and where are you going to conduct this actual place of the study. It has to be very clear. It can be a PHC, it can be your own operation theater, it can be PSU, wherever it is, you have to very clearly mention, or it can be OPD based study also. In that case, it has to be very clearly mentioned where the study is being done. And then you actually mention about the sample size, how many patients you are going to include in the study. And then you elaborate on what are the patients, who are the patients who are included, and then who are the patients whom you are not going to, who are excluded after including them. So, and then you describe in methodology the exact method or the technique, or how you proceed with the performance of the study, like practical application, like how do you shift the patient, how do you manage, how do you divide the patients into two groups, etc. And then you mention what are the assessment tools, like how do you define each and everything, what are the parameters you are going to study, and how do you define clearly each parameter. For example, you are doing a study on, as I told, intrathecal buprenorphine on post-op analgesia. You should define, if you're talking about duration of analgesia, what do you mean by duration of analgesia? That has to be clearly defined. And then what are the other parameters what you're going to study along with that? That also has to be clearly defined in your assessment tools and definitions. And so that's how you prepare a nice synopsis and then submit to the institution ethics committee, and then finally it is approved and you come across, you'll start doing the study. Now, when you start practically doing the study, what are the problems you can face? So the problems you can commonly face is, first of all, do you need a pilot study or not? Many a times, as previously told by Balbhaskar sir, pilot study is required for certain aspects, like it's not only about the calculation of sample size, but mainly it is to iron out how is the study to be done, and to help you to clearly define who are the study participants. First of all, whom to include depending upon your Picot and Finer criteria, and whom to exclude. Now, the question of exclusion comes depending upon why you are going to exclude. Most of the times, whenever you do a study, there are so many factors in the patients which can influence the outcome what you are studying. For example, if you are doing a study on post-operative analgesia, there is always a possibility somebody who is taking steroids, somebody who's on chronic analgesic therapy, might, those drugs which is routinely taking, if you don't take into consideration and if you are not going to manage that, then that can influence the outcome of your study. So therefore, those are the patients whom needs to be excluded. So we exclude the patients in whom either the patient factors or some other factors in which the patients are, the circumstances through which the patients are passing can influence the outcome of your study. So these factors are known as either bias or confounders, which I'll be discussing later in the subsequent slides. So therefore, to understand which kind of patients have to be included and excluded, again, is another problem faced, so which has to be addressed too. And finally, the next thing is data collection instruments. Many a times, when you prepare a synopsis, sometimes there is always a possibility that you will not go into the details. For example, suddenly you would have told, we will monitor post-operative nausea vomiting, we'll monitor for the hypotension, etc. But you would have never got through the literature sometimes, because many times it becomes a secondary objective. Many times interest would, focus would not been given to those areas, resulting in inadequate preparation. So therefore, again, you have to review and go through all those things and see whether all the data collection instruments are there or not. And therefore, again, there is always a probability of measurement tools and assay parameters. For example, many times you would have done a study on now suddenly you have spoken about respiratory depression, but you don't have enough people in the monitors or pulse oximeters in the ward to monitor saturation. Again, that is again a problem. So even before checking out all those things, sometimes you would have given the synopsis. And then plan for statistical analysis has to be done before you start commencing the study. So again, you have to take the help of a statistician there to see what all tests can be done, and he has to also understand what your study exactly is, so that will be helpful for him to advise your statistical test accordingly. And last but not the least, quality control and assurance at all levels. See, many a times what happens is the drug type of drug they issued might not be a standard one. Sometimes you will be using multiple tools or different types of tools for measuring the same parameter. For example, if you are doing a study on BP, each OT will have a different monitor. For example, one may have BPL monitor, one may have a Draeger monitor, and in other you have manual monitor. So invariably, all the monitors may have some amount of error into the equipment itself. So it's always important that you ensure that all of them are standardized before you recruit the patient in that particular OT and start using them for your study. So we were just discussing about the need for a pilot study. Of course, already Balbhaskar sir has already extensively talked about it. First thing is you should know whether you are able to do the study in your setup or not. So that is why you do a pilot study. You see what are the problems you can come across when you're doing that study, and you check out what are the deficiencies in methodology. Many times it so happens that you would have been you'll be doing a study on post-operative analgesia. So you're adding an opioid. You have not mentioned about the side effect parameters. You would have not taken into account the side effect parameters, and it would not be mentioned in your pro forma or in your assessment tools. So therefore, it will help you to see whether whatever pro forma you prepared for collection of data is proper or is it adequate or not. Many times when you share your pro forma with your colleagues or somebody who are going to do the study, sometimes they will be put in dark because certain parameters they are not able to understand. So all those things has to be clarified in the pilot study itself. So this gives an idea, this gives a chance for you to improvise your data collection sheet or your pro forma sheet, and that will help you to make the study much more uniform and much more that is again a part of your quality control. And then iron out minor practical issues in data collection. Many times you would be writing the data as 1, 3, 5 minutes, but your monitor doesn't have minute to minute recording of blood pressure. So again, at that point of time, you might have to see what is the most feasible technique and feasible method, and you have to modify it accordingly, and you have to go ahead with the further management of the further go into the study proper. So those are some things which you have to be addressed, so that can be taken care of when you do a pilot study. Likewise, and standardization of monitoring methods and tools. Many times what happens now, you are let us say you are using intrathecal buprenorphine for postoperative analgesia. Now you don't know whether that affects your motor blockade also. Now you want to study its effect on ambulation and motor blockade along with postoperative analgesia. So what happens? You would have used a bromide scale for recovery, but bromide scale, does it say that the patient can completely walk once the bromide scale is 0? No. Many times there is always a possibility that the patient is not completely recovered even after bromide requires 0. So therefore, you will have to see other criteria to make the patient ambulation. For example, ambulation after spinal anesthesia, there is a separate set of criteria. In addition to bromide scale, there are so many other parameters like loss of sensation of the, return of sensation of the soul, return of sensation of foot. All those things will be added subsequently. So therefore, in such situation, you will have to again review your requirement and accordingly go through the literature and see which can be optimally used for your study. Which parameter, for example, bromide scale, there are so many modifications. Which particular modification can be used in your study, and so on and so forth. These are the things which can be ironed out when you do a pilot study. Then once you do all those things, finally you come to the implementation of your study methodology. So you clearly mention where is the location of the study, whether it's a hospital, whether it's a community, whether it's an OPD. So you designate, and so therefore you alert the people there that you are going to do this kind of a study, so that they will be helpful to you in assisting you with the conduct of the study and conduct of the inclusion of the patients. Then you should very clearly define what is the duration of study, what you are going to do. And then, as I told already, we discussed about the selection of study design and study population. Now, and then prerequisites of some of the studies, such as study tools. I already have elaborated on these things just before, like how do you select the particular tool? There are tools, it's not exactly the tool, the technical meaning. For example, if you think of tool, it doesn't mean that it's only your BP apparatus, your pulse oximeter or nerve stimulator or whatever it is. No, it is beyond that. Anything which is used to any device, questionnaire, any grading or any system which is used to collect data in a particular pattern is known as a study tool. And next is the terminology. Terminology, as I already told, it can be onset of sensory blockade, it can be duration of sensory blockade, it can be onset of motor blockade, duration of motor blockade, duration of analgesia, or time to laryngoscopy. So there are so many terminologies you use depending upon the study you are going to do. So all those things have to be clearly defined. For example, time to laryngoscopy, you have to define it very clearly from the time of taking the laryngoscope in hand till you visualize the glottis. So this is how you define. And this definition, the reason why I'm telling all these things is because when somebody does your study again, you should be and apply the same kind of protocol. He should be able to easily apply your protocol, and he has to be able to carry out a meaningful study. So that is the reason why we have to define everything clearly. And then in case, as already Balbhaskar sir told, in case there is a deficiency in the technical know-how, or in the if there is any difficulty in understanding new procedures or anything, it's always better to undergo orientation training and programs before you start the study properly. Then, as I told you, there should be proper study tools for data collection. The proforma has to be perfect. It has to contain all the data. It should be precise, but at the same time, it should contain all the details what you're going to study, both primary, secondary, and other confounding factors and other factors which are also, which you feel that it is important to add to the information in the result section. And there has to be a proper planning, like how you collect the data, who is going to collect the data, and who is going to maintain it, and how are they entered, where are they entered, all those things. It has to be very clearly planned beforehand. This I'll be dealing in the subsequent slides also. Anyways, there are two important things which you need to understand. One is the data cleaning and analysis plan, which I'll be discussing in the subsequent slides as well. One of the most important prerequisites whenever you do a study is confidentiality. You should ensure that the patient confidentiality is maintained and there is no breach in confidentiality at any point of time throughout their study period. And it goes without saying that ethical clearance should always be taken beforehand. Before you start even the first patient, before you enroll even the first patient of the study. And many times it might require additional clearance from other things such as DCGI, Drug Control General of India, or animal committee if you are using any animal study on animals, etc. All those things has to be cleared before you implement your methodology. Once you're done with all these things, now you are going to select the patients. Now, how do you select the patients or the study population from the entire population? This is described by something known as sampling method. The sampling method describes how you are going to select the patients for your study. Then next, once you select, how many of them are you going to select? Is the next question. So that is answered by calculation of or estimation of a sample size. And once you collect how many patients are involved in your study, then you next go through the other ordeal whether they fit the inclusion criteria. If they fit the inclusion criteria, are there any factors which results in exclusion of those patients? So you check all those things and finally enroll them into the study. So then you actually ensure the standards of the study by various methods, various steps, that is known as the randomization, where you ensure that the patients are uniformly distributed into all the groups without patient factors coming into the play which can influence your outcome. Then subsequently you do allocation concealment, then you do blinding, you manage cover for bias and confounders, and then finally you do the study. You practically apply your study methods and do collect the data. And once you collect the data, it has to be properly entered and it has to be stored and entered properly in a legible manner. And then proper application of statistical methods has to be done so that finally your results will result in a proper meaningful conclusion. So subjects, depending upon the type of patients, depending upon the type of study, you select the subjects. Already I discussed this earlier. Suppose if you are doing a study on airway, you include all the patients who are coming for general anesthesia. At the same time, you are doing a study on LMA. So invariably, you have to involve all the studies whom you can place LMA. You cannot select a patient who's actually undergoing emergency surgery and requires intubation, isn't it? So you have to select the study patient according to the requirement. So you include them. Then later, see if there is any factor which can influence the outcome of the study. in them. For example, somebody has got an intraoral pathology. You cannot place an LMA in them, isn't it? So he's coming for GA, so he's included. But at the same time, he has got an intraoral pathology which can prevent the placement of LMA. So therefore, you exclude them. So therefore, they are the patients who are excluded from the study. So you need to understand that you can exclude the patient only after including them in the study. Suppose if you say ASA grade 1 and 2 is included, you don't exclude ASA grade 3 and 4 because you never included them at the first point at all. You never included them in the study. So therefore, a criteria for exclusion will be applied only after a patient has been included in the study. So that is the implication of inclusion and exclusion criteria. And later you classify them into two groups based on a random allocation procedure, which I'll be describing in the subsequent slide. Then you describe how, when, and where you are going to measure do the observations. Let us say you are doing a study on postoperative analgesia. You describe like how frequently you apply VAS score, like every 5 minutes, every 15 minutes, every 20 minutes, every 1 hour, every secondary. All those things you have to clearly explain. At the same time, you are doing a BP measurement following intubation. So you specifically mention 1 minute, 3 minutes, 5 minutes, 10 minutes, so on and so forth. You should be very clear, like what all parameters you are measuring, when and what is the timing at which you are measuring. And then in case if you are finding it difficult, it's always better to go back to the literature and find out what is the best way to describe it. So that will give you an idea. And suppose if you are doing a questionnaire or an interview-based study, which of late a lot of people are doing, you have to clearly describe what is the type of questionnaire you are using, and you have to get it validated before you use it for the study subjects. Then suppose if you are using a laboratory test, you see what is the standard value, what is the normal value, and when do you say it is abnormal. All those things has to be clearly defined in the methodology. And then if you are using clinical examination techniques, for example, auscultation of the chest or observation of cardiac sounds or measurement of a volume of pulse, etc. Whatever you are using, it has to be very clearly mentioned and standardized. Let us say you are saying respiration. You tell bilateral when there is air entry equal. It has to be very clear mentioned that you are saying that the tube is properly placed only when you auscultate. There is equal bilateral air entry on both sides. So that's how you have to very clearly explain and define what is your end point. So when you are depending upon the type of study you do, the sampling technique can vary. But what I would rather say is, why is this sampling technique is important is because you cannot study the entire population. So you select a set of people from that set of population in whom you are going to planning to implement your research observations. So you select a simple sample population from that large population group and see that they are adequate in size. Suppose if they are small, they do not reflect the proper true and valid differences in the outcome. If they are large, many times it becomes time consuming, uneconomical, and unethical. So therefore, it's very important to assess the proper sample size. Depending upon the type of sampling, it can be probability or random sampling or non-probability sampling. I'll not go into the details of this because it's a little complicated. But what you need to understand is most of the time it's always preferable to go for probability samplings. Probability sampling is the type of sampling method where every person has got a definite chance of getting involved in the study. So this is more suitable for a scientific basis, and it is a gold standard for generalizability of your observation. And also it is helpful for computing statistical significance and confidence interval in a legitimate and scientific manner. So various types of sampling, probability sampling methods are available. Simple random sampling. That means, so any patient who for example, you are doing a study in on patients on intrathecal. As I go back to the same old example, you are doing a study on intrathecal buprenorphine. You are going to, as I told, the sampling will be from the patients whom they are going to receive spinal anesthesia. So you clearly define all the patients who are going to receive spinal anesthesia is the population here. Among them, you select, for example, the patients who are coming, let us say during the first week of month for spinal anesthesia, or let us say all the consecutive patients who are coming to operation theater and receiving spinal anesthesia for any surgery will be included in the study. So this type of sampling is known as simple random sampling. The next method is systematic sampling. Again, this is a simple random sampling is the most commonly followed technique what we do routinely in our anesthesia practice. Next is systematic sampling. That means you select every third patient who receives spinal anesthesia in your OT, or you select every fifth patient who is receiving spinal anesthesia in your OT. So this is known as the systematic sampling. So basically, in order to this is done on for a particular in certain set of situations where you feel that involving all the patients sometimes might not be feasible. Next method is known as a stratified random sampling, where you divide your set of population into various subgroups. So for example, let us say all the patients who are coming to your OT to receive spinal anesthesia, you are involving in the study, but you want to see how each subset of patients, for example, let us say patient with 21 to 40 years, patients with 41 to 60 years, how they react to this particular drug. Likewise, patients with hypertension, patient with diabetes, how they react to this drug, you want to see. So what you do, you select randomly 5 patients from 21 to 40 years who are coming to your OT, and you use them as one subset. Then subsequently, you add another 5 patients who have hypertension, then another 5 patients who have diabetes who have come for spinal anesthesia in your OT. So likewise, you reach up the sample size of 30 by going on adding 5 patients of all each your subset. This is known as stratified random sampling. The advantage here is that you are going to involve all set of patients, all types of probabilities. But the problem with this type of random sampling technique is that many a times it will not reflect the true outcome of the study. Sometimes it might be underpowered, or it can be the results what you obtain might not be the true effect, or sometimes true effect, or in a sense it cannot be the true results. Next is the cluster sampling. So where you go to this is most of them done in a epidemiological study. We can also in anesthesia, if you think of cluster sample, we can go on doing a study of let us say you are doing effect of now COVID. We had a lot of COVID patients. So you are trying to see the effect of tofacitinib or baricitinib on lung parameters in patients with COVID-19. So you don't have enough patients. You want to see how it is applicable in all places. So what you can do is you can select 10 randomly. You can randomly select 10 patients in your ICU, 10 patients in your neighboring hospital ICU, 10 patients in some other private hospital ICU. So that will represent the outcome of the particular drug in the entire city population of your city, because you have included different types of population in different. So for example, there might be a government college, there might be a private college, there might be a corporate hospital. You collect 10 patients from all the patients and do a study, and this type of sampling is known as cluster sampling. So I'll just go to the technique of randomization, random sampling now, and randomization. So effect of now, one thing what I need to explain you here is random sampling and randomization are two different entities, and they are not common, and they cannot be used together. So that is what I want to explain. So let us say there is an effect of femoral nerve block on pain relief for fractured femur. So random sampling says that all consecutive patients that are posted for a fractured femur under subarachnoid block can be used as a sample or a patient for your study. So this is explained by simple random sampling. At the same time, every third patient you use for every third patient who is posted for fractured femur, you select for your study. This is known as systematic random sampling. Stratified random sampling, as I told, 5 patients with diabetes with fractured femur, 5 patients with hypertension with fractured femur, 5 patients with long-standing fractured femur, 5 patients with acute fractured femur, 5 patients with some other, let us say, fractured femur with this one. So likewise, if you go on stratifying them and included them in the final sample size of 30, then that becomes stratified random sampling. So this is about sampling. Now you know from where you select the patient. Next, how many patients is determined by calculation of sample size. So as I told earlier, if you don't have adequate sample size, many times achieve the statistical significance, and the result may not be consistent, and it can result in questionable validity of research. At the same time, if you are involving large number of patients, it can result in unnecessary exposure of the patient to a new drug, and it can result in greater economical and ethical burden. So what are the requirements you require for calculating a sample size? First, you should have an hypothesis. Say it can be null hypothesis or alternate hypothesis. Null hypothesis state that drug A and drug B are equal, whereas alternate hypothesis can say that drug A can be higher than drug B. So that is about hypothesis. You should have a clear hypothesis what you are going to test. Later, you should clearly define a primary outcome. This I already mentioned in the beginning of my lecture itself. This is one of the important aspects, because your primary outcome is the one which helps you to calculate the sample size. So even if you describe a study on postoperative analgesia, you should clearly define what component of postoperative analgesia is your primary objective. It can be duration of analgesia, or it can be 24-hour analgesic requirement, or it can be the reduction in the VAS score. All those things can be primary outcome, but you have to define one of them clearly. And then once you define what is the primary outcome, you have to quantify them in the form of mean, proportion, or percentages. Suppose if you are using duration of analgesia, you describe it in the form of mean and standard deviation. Likewise, if you are doing a study on postoperative nausea, you explain them in the form of proportion, like 25% PONV, 25% incidence, 40% incidence. So you have to define what you are going to use as a measurement parameter for that primary outcome. Then subsequently, there are 3 assumptions which has to be made: 2 errors and 1 effect size. So 1 errors are alpha and beta errors. Alpha error is the error which says that a thing can happen even without your intervention. That is, which can happen by a random chance, but still you say that the drug can be better. So you have to keep the alpha error as low as possible. And the other error is known as the beta error, which is which explains the error that can occur when a drug you give, actually the drug has got a effect, but when you do a study, it appears as if the outcome doesn't show any effect. This is a type of an error is known as beta error. So alpha and beta error, power is the opposite of beta error. So if you are using beta error of 20%, the power will be 80%. If you are using a beta power, if you conversely, if you mention that the power of 90%, that means your beta error is 10%. So that's how it is. So this is about errors. And next important thing is the effect size and the variance. Now, what do you mean by effect size and variance? Effect size is the minimum difference what you are trying to study between the 2 groups. So let us say you are using a buprenorphine intrathecally. So you assume that your hypothesis is buprenorphine can prolong analgesia when compared to placebo or when compared to control. So you explain the primary outcome measure as duration of analgesia, and you explain in the terms of you decide to measure that in the terms of mean and standard deviation. So you assume the effect size, that is the difference between the 2 groups, that is the patient who receives buprenorphine and who doesn't receive the buprenorphine, to be at least minimum of 60 minutes. That means the duration of analgesia, let us say if in group A who doesn't receive buprenorphine is 300 minutes, you presume or you assume that adding buprenorphine to intrathecal can result in a duration of analgesia of at least 360 minutes. So if you see the difference between the group A and group B is 60 minutes. This is the effect size what you are actually assuming. And next second half is the variance. Variance is the standard deviation. That is the amount of variance you are expecting in the patient. So this again you can either assume or you can get it from the previous studies. So usually, as I told, you can aim for only one outcome measure. Already I told, if the studies on postoperative analgesia, duration of analgesia, or 24-hour analgesic requirement. If you are doing a study on drug using in ICU outcome, you can use the duration of ICU or duration of mechanical ventilation, and then describe them in the terms of means and proportions. And effect size, already I told. Effect size can be either obtained from the pilot study or the previous studies or using a clinical judgment. Here is the role of the guide. The guide can clearly help the student in determine the effect size, because that will go a long way in calculation of the sample size. And subsequently, the degree of variation, again, it can be obtained from pilot study or previous studies, or usually it is standard deviation for continuous variables whenever you are using mean and standard deviation. And this variance is not required when you are using proportions. For example, PONV, percentage of PONV in group A and group B, when you're trying to compare for calculation of sample size, you don't require this variance. So power of study, as I already described. So power of study, most of the time it is the reciprocal of beta error or type 2 error. So as I told, a power of study of 80% means that the alternate hypothesis would definitely be correct in 80 out of 100 instances. This is the this is what you understand by power of study. Greater the power of study, greater the likelihood of true positive outcomes and lesser false negatives. That's why it's always preferable to keep the power of study at least more than 80%. Next is alpha error. Alpha error is nothing but the ability of the study to pick up. It's an error which can happen when the drug A and drug B doesn't have any effect, but still drug B is shown to have effect. So which can happen due to some inherent problems or inherent characteristics of the patient. So generally this can result in very devastating outcomes if you keep a very high alpha error or type 1 error. So therefore it is always customarily kept at 5% or less than 5%, depending upon the quality of the study or type of the study. So the impact of false positive error can be more detrimental than that of a false negative. So therefore alpha type 1 error should always be kept lower than type 2 error. That's why we customarily keep alpha error or type 1 error at 5% and beta error at 20%. The next method, the next step in manage, once you calculate the sample size and enroll the patient, next is to ensure that they are uniformly distributed in the study groups. So how do you follow that? Is by doing randomization. So what do you mean by randomization? Is a process of ensuring the uniform distribution of patient characteristics into the study groups. So therefore you remove the selection bias here. So how do you do? You just take a sample of a random table. Usually these random table numbers are available in network, and you select a set of numbers. Let us say if your number of patients involved is 30 in your study. So you select say somewhere, either you can take this one, though I have showed the from here, I can take from here, here. You select a set of 30 numbers and then you write them and you design one particular parameter. Let us say all those digits which are 0 to 4 will go for A, and all those digits which are less than 5 to 9 will go for B. So if you put that, so this is how you get. So random number sequence 1, 3 is 9, 6 to 7 is the sequence you got. So case number 1, his random number sequence is 1. So he goes to group A. Case number 2, his random sequence is 3. So as we know from the previous slide, it is less than 4. So again, he goes to group A. Likewise, patient number 3, his random sequence is 9. So as per our previous this one, 5 to 9 will go to group B. So therefore it is more than 5, he will go into group B. Next, patient number 4, his random number sequence is 6. So it is more than 4. Again, he will go into group B. Likewise, so the patients will go on based on the random number sequence generated, they'll grow into group A or group B based on this random sequence number. Many times it might be difficult. So one of the easiest methods in the statistics, we can go for some software like random.org. So here, when you open this software, when you open this website, these are some of the things what you get. So you go for selection of sequence. It will ask random numbers, random sequence, whatever it is. So we click on random sequence. So this is the area which we get. So here it will ask you to mention the lowest value and the largest values and how many columns you want. Suppose if you are having 2 groups in your study, let's say A and B, you can mention format in 2 columns. Suppose if you have 3 groups, you can mention 3 columns. So then click on the get sequence. So you will get, so you enter these values and format in 2 columns, and then click on get sequence. Then this is the sequence what you get. See, this will be the group A and this will be group B. So patient number, if I go back, patient number 36 will come to group A, 51 will go to group B, patient number 1 will go to group B, patient number 4 will go to group B, patient number 2 again will go to group B, patient number 3 will go to group B. So like that, so based on this, you can allocate the group into group A and group B. So this ensures that the patients are uniformly distributed without any selection bias. Now, the other method is stratified randomization, as I told earlier. This is similar to randomized random sampling. You select the population and among them randomly select like 26 to 45 years, one set of patients, 46 to 65 years, another set of patients, and 66 to 85 years, another set of patients. And finally, you make a simple sample from a sample size. This is known as stratified randomized randomization technique. Now we're done with randomization. Is it enough to ensure that the study is conducted without any bias or any this one? No. Still, what will happen is, many times what happens, now already you have generated a randomization table. According to that, patient number 1 go to group A, patient number 2 will go to group B, like that it's already known. Now suddenly you are posted in an OT where the surgeon is less skilled, but the patient is expected to receive the standard. Then you feel that already the drug, new drug is going to act for a longer time. Then you will tell, okay, I'll not give standard drug. I'll go and give the test drug because I want it to act for longer time. So actually what you are doing is, though the randomization is created, you are creating a selection bias by tampering with the randomization sequence. So that is the problem. So now how to cover this problem? And this can be done by allocation concealment. So what you do in here is, you just mention you generate a randomization sequence and then write it on a sheet of paper and put it in a sealed envelope. And this envelope is numbered in a sequence like 1, 2, 3, 4, 5. So case number 1 will get envelope number 1. Case number 2 will get envelope number 2. But what is there in the envelope or the randomization sequence, what number is there inside the envelope is not known to anybody. It will be known only when you enroll the patient, ship the patient to OT, and then open the envelope. That is when you know whether the patient belongs to group A or group B, and you can still administer the drug accordingly. So the problem here is, again, the investigator can still modify here. He can intervene and say, okay, no, no need to put it in group B, we'll put it in group A. So this, still he can overcome this. Now, how to overcome that part? That is done by blinding. That is, this allocation concealment, once it is done, the envelope is opened by an additional person who is not involved in the study. So he will open up the envelope and he will see whether the patient belongs to group A or group B and prepare the drug solution. And he will come and give the drug solution to the investigator and go off. He will not stand with the patient, or he will not stand with the investigator to say what is in there in that. He will just prepare the solution as per this, as per the group allocation, and he will go off. And the person who is going to administer the drug, or the investigator who is standing and ensuring that the student is administering the drug, will not be aware of what is there in the syringe. He will just administer in the syringe. Now, this technique is known as blinding. This procedure of doing that is known as blinding. So what are the types of blinding? It can be single blind. It can be not blinded at all. It can be single blind where the patient is blinded to the intervention, but the investigator is known. At the same time, double blind, the patient and the person who is administering drug is blinded. Triple blinded, patient, the person who is administering drug, and the person who is standing and monitoring the patient. All the three are unaware of what is the drug being issued. So this is known as triple blinding. So you can blind as many people as possible to ensure that the study is carried out in a proper method. The present scenario, nobody mentions clearly like double blinded, triple blinded, and all. They just mentioned that it was blinded. If blinding is not possible, certain places, for example, you are trying to test 2 different devices and the person has to be there when the device is there. In such situation, you can standardize the treatment of the groups, or you can use an objective measure, or consider an expertise based trial design. Sometimes you can use objective or reliable outcome. Sometimes you can also acknowledge that as the limitation of your study. So there is a difference between blinding and allocation concealment. Allocation concealment ensures that the treatment to be allocated is not known before the patient is entered, whereas blinding ensures that the patient and physician is blinded to the treatment after the enrollment into the study. So once you have done all these things, you actually start conducting the study, do the study. So for that, you have a proper protocol, you iron out all the minor deficiencies, ensure that the measurement tools are standardized priori, and then ensure that all the scales used to measure data are already validated or present, used as per the existing scientific evidence. And finally, it should be a honest and unbiased follow-up and reporting. There should not be any bias created. So how do you go about this? Lay down proper protocol. So the main problem what the student can face is incomplete and improper proforma. So therefore, as I told earlier, a proper proforma has to be prepared based on the input from the pilot study. There has to be the proforma should contain proper space for patient demographics and hospital information. All tools and assessment parameters should be, which is used as a support for your assessment tools, has to be mentioned in the proforma. And also you should make a mention of secondary outcome also in the proforma, so that all those things are also recorded. It is not missed out. Then ensure that there are proper measurement tools by use of a common equipment throughout the study. Like for example, you are using automated BP apparatus, use automated BP apparatus itself in all the places. Don't use manual one place, don't use automated at other place. If you are using BIS monitor for depth of anesthesia, use BIS monitor only throughout all the studies. You cannot use BIS in one place, entropy in one place, or narcotrend at other place. Likewise, you have to use a common or a standard equipment throughout. And do not add new things in the middle of the study. Like suddenly now you are doing the study and suddenly you notice that you are doing a study on postoperative anesthesia. Suddenly the patient got decrease in shivering. So now you wanted to add shivering also. You cannot add to the performance the shivering parameters also in there. You can just mention shivering yes or no, but you cannot add grading of shivering, etc. once the study has already commenced. Likewise, validation of the tool with the standard equipment. Whenever you are using a newer tool, for example, you are using a newer BP equipment or newer anything, you actually compare with the standard equipment before itself. And you should also ensure that all the scales should be appropriate and validated, like VAS scores, PMA scores, motor blockade, questionnaires, patient satisfaction scores. All those things have to be properly validated before during the study. And then honest reporting should be done. Once you record the parameters, you record it as it is. Don't try to tamper, don't try to manage to suit the outcome of the study. You have to mention all those things, and you have to record it as in how it occurs. You need not tamper it. So therefore, it will not affect your outcome. It should not affect the final outcome of your study. So there is always a possibility of errors in research, which can be due to the patients as a role of chance or random error, or it can be due to a systematic error that has been building in the study design, which is known as bias, or due to an extraneous factor which is present in a patient, which can affect both the disease as well as the exposure. This is known as the confounding. So bias means it's a systematic tendency of any aspects of the study design, conduct analysis, which can influence the outcome of the exposure or measure of the outcome. It can deviate from its true value. This bias can induce a deviation from its true value. Likewise, it is mainly a problem in the study design itself, which results in this particular bias. There are various types of bias. For example, if I just take what is the bias, the study, if you are doing a study of incidence of postoperative complications in tonsillectomy patients in children. Okay, now you are not recording the incidence of upper respiratory tract infection in these patients. So invariably, those upper respiratory tract infections can result in outcome. It can result in change in the outcome. So especially those who are already having active upper respiratory tract infection can have higher incidence of post-operative respiratory complications. But if you don't record that, that is one which is creeping in, and it is creating a change in your outcome. So therefore, this particular factor is known as the bias. The bias can be patient bias, it can be measurement bias, it can be at the time of recording, or it can be at the time of statistical analysis also. So these are the various types of bias. So our methodology should be strong enough to avoid all these biases. So selection bias may be due to imbalance in baseline characteristics. So therefore, you use randomization and inclusion exclusion criteria properly to avoid this selection bias. Then there can be measurement bias due to reporting of the patients, or sometimes when you try to ascertain from the patient, for example, VAS scores, when you are trying to ask, you ask patient, pain is less or more? The patient may say pain is less because he's seeing you. Or sometimes performance bias can creep in, or sometimes recall bias. The patient is not able to recall what happened to him earlier. So he may say that it has not happened. So this is known as recall bias. And many times the observer will know what kind of whether the patient belongs to case or control group, and he will record it can influence the recording of the parameters based on that. So this is known as observer bias. Next is confounding parameters. That is, whenever you are doing a study characteristic and you try to study the outcome, there is one more factor which is present inherent in the patient. You don't notice that, and that can result in the disease, which can also contribute to the disease. For example, you are doing a study on effect of coffee consumption on pancreatic cancer. Now, you know that many times whenever smokers do a smoking, they also simultaneously drink a cup of coffee. So invariably, many patients will have smoking as one additional confounding factor. But they will be, so you are included them also in the study. So invariably, you are trying to assess coffee consumption in pancreatic cancer. And this smokers can influence both coffee consumption as well as pancreatic cancer. So if you don't take this into account, it can distort your results. So keeping all these things in mind, you do a performance study and finally collect data. Then what next? So let us say you are doing a study on intrathecal bupivacaine, as I told you, clonidine versus bupivacaine. So the primary outcome measure is duration of anesthesia, secondary outcome are duration of sensory and motor block. You enter them in an Excel sheet like this by putting various parameters. These parameters are known as variables. So they have to be entered into these variables, and before you submit this into to the statistician, you do certain thing known as data cleaning. Data cleaning means you just review the chart, compare it with your pro forma, and see whether all the data you entered is right or wrong, all the data you have mentioned is right or wrong, or there is any duplication, or there is any number entry. For example, in the urgency to enter, many times mean arterial pressure, instead of mentioning 77, you would have mentioned 777. This is because of typing error. But if you don't check that, eventually that will be reflected when they do statistical analysis. Invariably, you will have a wide standard deviation. So that can affect your outcome results. So therefore, it's always better to review all those things and check you do. And sometimes in some patients, you are talking about duration of analysis. Some patients, the surgery ends before 60 minutes. Some of them, it ends beyond 70 minutes. So you check all those things and see if some of them, if somebody's surgery has lasted less than 50 minutes and somebody's surgery which has lasted for more than 120 minutes. So there are some 2 patients like that. So those 2 are known as outliers, and those patients can again influence the outcome of your study. So either you acknowledge it in the results or you remove them from the variables list. So this is known as data cleaning, and then you classify them as you describe them in the form of groups, because you cannot measure you cannot describe the entire mass chart. So you describe them in terms of certain numbers or measures. That is known as descriptive statistics. And then you apply, once you describe them, you apply various statistical tests to get a valid outcome or inference. So that is known as inferential statistics. So descriptive statistics can be quantitative or qualitative. Quantitative means when they are described on the numerical scale. Qualitative means they are basically described on quality. It cannot be quantified. So I'll just example of example of quantitative data is weight, BMI, duration of surgery, duration of analysis. All these things numbered in black are quantitative data, whereas gender distribution, ASA physical distribution, they are all qualitative data. So again, quantitative further divided into discrete and continuous. So continuous means, for example, duration of analysis is a continuous data, whereas incidence of P1V 5 out of 50, 7 out of 50 is a discrete data. So again, if you know, this is about quantitative. Now coming to qualitative, they can be either ordinal or nominal. Ordinal means ASA grade 1, 2, 3, 4. They are described in a particular order or sequence. They are known as ordinal. Nominal means blood group. For example, it can be gender, male or female, or blood group AB, ABO. They are not arranged in an order, but they are discrete. Each one of them are discrete and individual. So gender is nominal data. ASA grade 3 and 4 are ordinal data. Again, motor blockade grade 1, 2, 3, 4 is an ordinal data. So again, revising that, qualitative again classified as ordinal and nominal. Ordinal means severity of disease, grading of disease, etc. Nominal means gender, blood group, treatment groups, outcome, etc. Likewise, quantitative again discrete or continuous. Discrete means number of asthma attacks, number of patients admitted, number of ICU days, etc. Continuous means age, height, weight, BMI, heart rate, blood pressure, etc. Sometimes the same parameter can be expressed in different ways. For example, smoking status. If you describe them as classify them as smoker or non-smoker, they are classified as categorical data. If you again classify them as heavy smoker, light smoker, ex-smoker, non-smoker, then they are arranging in a particular sequence. So they are known as ordinal data. Based on smoking, if you classify the smoking status based on number of cigarette smokes per day, then it becomes a discrete data. So that's how one data itself can be presented in multiple ways depending upon your research question. Again, the variables can be dependent or independent. Independent variables also are the ones which are varied or manipulated by researcher. For example, let us say you are having group A and group B. Group A receives intrathecal clonidine, group B receives placebo. So this is manipulated by the researcher. So therefore, group A and group B are the independent variables. That is, it is not dependent upon the outcome. You are actually creating that variables. You are actually introducing that variables. So this is manipulated by the researcher. They are known as the independent variables. Dependent variables are the responses that are measured. That means it represents the response to outcome, response or outcome that the researcher wishes to predict. For example, now you are given intrathecal clonidine. What do you expect? That is the motor blockade, sensory blockade, duration of analgesia, hypotension. All these things are the things which happen due to administration of intrathecal clonidine. So therefore, they are the response that are measured. So therefore, they become the dependent variables. So this is just an example. Different types of laryngoscope blades. The independent variable is the Macintosh and the Wiener blade, and the dependent variable will be time to intubate, number of attempts, and the incidence of trauma, etc. So likewise. So now, likewise, you have effect of age, gender, and weight on duration of deoxygenation. So age, gender, and weight are the independent variables, whereas change in saturation at 1 minute and 3rd minute, time required to achieve 100% saturation is the dependent variable. Now, what is a confounding variable? Confounding variable is a variable which can influence the effect of independent variable on dependent variable. Now, let us take the first example itself, Macintosh blade versus Miller blade. So, now if you include, let us say in the study, patients in whom there is limited mouth opening. So invariably, it can influence the placement of blade also, and it can at the same time prolong the duration of intubation also, because there is limited mouth opening, difficult to pass the tube. So therefore, that is known as the confounding variable. So as I told you, data cleaning process is to find the missing data, clear the duplicate entries and detection of outliers. And then you describe the data in the form of mean, median, mode. That is a central, these are known as the measures of central tendency. And how the data disperses around this central tendency is the measure of dispersion, which is expressed in the form of mean, standard deviation, standard error, range, or interquartile range. So measures of central tendency include mean, median, and mode. This is how you represent. Measures of dispersion include range and percentiles and interquartile range. So therefore, a poor planning and methodology is not only results in unreliable and wrong outcomes, it also results in poor dissertation writing and future publications. Thank you. Thank you for patient here.
Thank you, Sudhir. You nicely narrated how to do the methodology in your research. It is actually 2 hours topic. You concised with 40 minutes. So thank you for for strictly adhere to the time limit. And we are move on to the third topic. Now we know the research question. We know how to write the methodology. Now how to go about the methodology. Now the third topic is how to write the dissertation by Dr. Rakesh Garg. He is an additional professor in the Department of Anesthesiology and Palliative Medicine of AIIMS, Delhi. He had more than 260 publications in his credit, and he has authored more than 25 chapters in the books. He is the co-author of the guidelines, that is COLS, and he is the trainer and instructor for BLS, ACLS, and COLS. He is in the editorial board member and reviewer of international and national journals, and his area of interest is anesthesia, airway research, cancer pain, and palliative medicine. He received many awards. Over to you, Rakesh.
Thank you so much, sir. So is the slide visible?
Yes, sir. Yes, sir. It's visible. Sir.
Yeah, thank you so much. I think after the 2 good interactive session, we will be going through how to write the dissertation. So I think whatever has been discussed in the last few sessions, everything has to be translated into the writing format, and this is the important aspect. So when we say dissertation, it has already been discussed by Dr. Bala Bhaskar that it is one of the essential requirements for various programs, and the research that has been done needs to be documented into a long formalized form of essay in which you generate a topic or an inquiry or a plan and execute the project that investigates it and write up what you did and what you found. So basically, this is not exactly a publication. This is a little long format where you describe in verbatim, because dissertation is a learning process. So it has to be written in a little more detail. Thesis and dissertation has been used in interchangeable format. So I think nothing to worry about it. Some people say that thesis is a shorter version of dissertation. Dissertation is more long, especially for postdoctoral programs. But when we say the steps that needs to be going through it, so probably I want to say there are 2 aspects when you have to write the things. One is the protocol submission, which will make a major part of your dissertation writing, because majority of component will be in the protocol, and some of the outcome of the research will come into the dissertation when you'll be writing it. And that's why, as Dr. Bala Bhaskar was mentioning, that there will be a role of supervisor also in this, which will help you going through the various process of research that we have discussed. So I think this research process that we are talking about must be elaborately written in words. Sometimes we take it granted that the patient, the study is a 2-group study. Study is a prospective study. So we assume it is, and we forget to write it in the dissertation, and that creates a problem when it is being reviewed by the thesis reviewers or the external reviewers, which is being sent by the university or the college. When we say you're writing the process, says there are 2 things about it: doing research and managing research. I think doing research, we have already discussed so many things, and managing research is that you need to put it into the words, so that if anybody else reads your dissertation, they will be able to not only understand, but if they want to replicate it in a similar format at some other place, they should be able to do exactly the same way. And that's why it requires supervision, because it is being done by postgraduate. It is a part of their learning process, and hence the responsibility of the supervisor or the guide to guide them, so that not only they make a time frame, but they also understands that how to write each aspect of the dissertation, so that if they are being defended for the proposal or the thesis, final thesis submission, they can do it. And also, as sometimes it will be required to revise them and submit them subsequently. We have already discussed in detail that why do we need dissertation. So probably we'll not go into detail, but basically what we need to understand is that we may not be required, as Dr. Balabhaskar was saying, that we may not be required a very landmark study, which is absolutely novel. But what is required from the dissertation is that each process or each step of the research, which was nicely described by Dr. Sudesh and previously by Dr. Balabhaskar also, that the student should understand how each step is being done, what is the importance of each step, and how to document them. And that is what the dissertation done is. And obviously, if somebody had a good publication in a good journal, that is definitely a final point, end point of this. So when we start thinking of the student is allotted in a guide, so we should start early. I am talking about the writing aspect, but don't think the writing aspect will be happening at 2.5 years. It should be starting, it should be from the day when you have been asked to submit a proposal for dissertation. So you start early and continuously collect the information, various articles, and keep them, so that you are able to get all the requirements, all the information, all the references when you are writing them. You observe and explore and make full use of your classes from various aspects, because many of the things will be interpreted when you are writing the dissertation. You have an outcome, but you need clinical interpretation. There could be a statistical interpretation that will be given to you by your biostatistician, but you need to clinically interpret them, that whether equipment A is better than equipment B clinically. Maybe the p-value is more than 0.05 in this situation or less than 0.05. So you have to make clinical interpretation, whether the difference of duration of analgesia of 1 hour is clinically significant to you, whether the timing of intubation of difference of more than 2 minutes is clinically significant to you. So keep absorbing your clinical knowledge, your clinical experience throughout the research project, so that when you write the discussion section of a dissertation, you are able to do so. When you start your dissertation, I think this has already been covered, so I may not be going into much detail, but choose a topic of a research that is of interest to you. And we have already discussed various criteria. Probably I'll be repeating some of these again, because these are the most important aspect. But you need to write or search a research topic which is the expertise of your supervisor, the available equipments, and the patient population is available and remains interest to you. But before you write a dissertation, a protocol is also required, because it is be approved by your academic committee, research committee, or ethical committee. And hence a research protocol is very, very important to be written. And this gives you almost half the work of dissertation, because the introduction, the aims, objectives, the research question, the method section, the possible application of statistical tool, the sample size will remain the same. What you need is, during the research, whatever you have obtained the data, you need to analyze them, and then you need to interpret them in the discussion section. That is added on to in the dissertation part. When you submit your proposal or a protocol, try to include these mandatory things: the title, which is primarily based on the primary research question; the outline of the topic, which is sometimes also called the introduction or the background, which should also include the aims and objectives. An objective should be the primary and maybe sometimes secondary also. A thorough review literature which highlights the importance of your study. Though we usually expect that it should be having some novelty, it should not be absolutely duplicate, much old. But for the dissertation purpose, we may not be expecting a very novel idea, or maybe absolutely a landmark article, but we expect is that it should be a relatively something new. It should not be an article, say comparison of say Macintosh laryngoscope with some other previous like McGill laryngoscope, which has been used earlier, for the purpose of comparison for the intubation purpose, because this has been done decades earlier and may not be having any type of recent novelty. The research method section we have discussed in the last section. Each component of the research methodology must be included into your research proposal. The project schedule, the time frame should also be documented. That is very, very important. So your thesis protocol should have these headings, which are mandatorily. There would be sometimes the institutional format that is sometimes required, and that needs to be covered. Majority of the protocols will have some of the title page like this, which is being followed at our institute. We need to follow the same format for submitting our protocol. The title of your research protocol, this is one of the thing that needs to be written at the last, because once you are think of your methodology, your study design, your groups and almost everything, and your primary research question based on PICOT is ready, then you can write the title, which should be informative, preferably a one sentence, specific, relevant, and try to avoid the abbreviations here. Now, thesis topic, I just mentioned that you should choose the thesis topic, which is your of interest. You have the facilities for the same patient. You have the patients available for them, and you are able to, don't try to pick up a disease or a procedure which is very less frequent at your center, because this is a time-bound project which you need to complete at some places in 2 years and some places 2.5 years, and hence you should be very, very clear. When you write the introduction of your dissertation or your protocol, there are basic 3 aspects into it. That what is known presently, what are its limitations, right? So you move from what is known to what are the gaps or the limitations, right? And this is usually based on your review of literature or your experience or your colleagues' experience, and then how those gaps can be filled. And this becomes your basically the justification of your research. So whenever you write an introduction, the sequence needs to be followed in the same way, culminating into a proper PICOT-based research question. Now, subsequent to your introduction section, you need to mention the review of literature, and it must include what, why, and where. And the review of literature should be very systematically mentioned. I will be coming more detail a little later, but you need to summarize the knowledge about the magnitude of the problem that you are considering in this particular research question. And then you discuss them and try to summarize it. This is always a good option, that in your dissertation, you should always try to summarize the into a tabular format. Whosoever is reading the dissertation knows that these studies has been done. This was the objective for those studies. They found this limitation, and that's why you have taken your research as a research question based on this. So this tabular format is always good when you write your dissertation, probably in a protocol also. The aims objective, the research question hypothesis must be documented into your protocol as well as your dissertation very clearly, and this has been very nicely covered by Dr. Balabhasar earlier. I may not be going into detail, but do mention about that whether your research question fits the final criteria. Include all the components of PICOT into a research question when you're documenting it. Majority of time, we forget to write the study population. We say we want to compare Macintosh with video laryngoscope in which patients. So don't try to miss any of the components, right? When you write a research question, your title, just check whether all the components have been compared and put into the research question that you have developed based on your review of literature, and must be documented nicely. Also, if you can put a word on the objectives by putting the smart and justify, specifically when you are writing a research proposal for protocol approval for the dissertation, you should be justifying that whatever the research question you have developed and subsequently the objectives, you are able to do them into a time-framed manner. Because I am repeating again, for the faculty-based study, they can do it for 3 years, 4 years, 5 years. But for a research, which is thesis or dissertation, needs to be finished either in 2 years or at some places 2.5 years. So you should be very clearly mentioning that your approximate patient population is 50 per year. So you will be able to complete 100 patients in 2 years. And hence this justification must be mentioned there. Also remember that the objectives in your dissertation should not be too much, but whatever you decided a priori, you must document them based on your PICOT question clearly into your protocol as well as your dissertation. Remember, it is always good to have a single primary research question than multiple questions. Make the study more simpler. Methodology has been discussed in detail by Dr. Sudhish, so I will not be going to detail, but remember, method section should be in such a detail in both protocol as well as dissertation, so that if somebody wants to do it again, he can do it in an absolutely similar pace. So this means that very minute detail, for example, somebody wants to measure the BP, you should mention the BP will be taken in supine position after 10 minutes of rest in the right arm by using a non-invasive blood pressure, using an automatic sphygmomanometer. So this will give a clear idea that who is taking it, how it's been taken, what is the position of the patient, what equipments has been taken. So this should be described when you are taking up these type of description into your dissertation. So this has already mentioned that when you are reporting your methodology, your study design, your study period, study subjects, the sample size, the methods of recruitment, the randomization, blinding, intervention, record of co-interventions, follow-up, the outcome of interest, they must be documented in verbatim. Just for example, you should describe that all the patients presented into the PAC clinic will be screened, and then you should try to study sample. You should describe that how randomization sequence was generated, what system was used, and how you divide it into 2 groups or 3 groups. You should also clearly mention dissertation. This is important aspect because your thesis or dissertation can come back even if you may have done it, but if you have not reported into a dissertation that how you did it, probably this will not be clarified to the evaluator, and they can send you back that this has not been done. So do mention that what process of allocation concealment. If you have used the snooze technique, mention that after randomization, allocation concealment was done using snooze technique. You also must describe the technique of blinding and masking, because sometimes you can blind, sometimes you cannot, and there are various ways of blindings. For example, if you want to use a syringe, if they are of same color, but volume is different, then you need to dilute them. If they are of different color, for example, say propofol versus thiopentone, probably you have to cover the syringe with some opaque paper. So this means you need to mention the clear mentioning that how the blinding or masking was done into a study must be clearly mentioned into the method section of dissertation. That should be very clear. Also, you should be very, very clear that what type of statistical analysis has been done, because now you have the data with you when you are reporting your dissertation. You know, Dr. Suresh has already mentioned about the variables and various statistical tools that we need to use it. So you need to mention that these were the variables. They were numerical versus qualitative. They were Gaussian versus non-Gaussian. For Gaussian distribution, you have used this statistical tool. For non-Gaussian, you have used, and you have to be very specific. For example, age will be compared using this. The A weight was Gaussian distribution was compared with this, and it's being dependent mean. So we cannot make a blanket as we do for some of the studies earlier that the statistical analysis was done as required. So this is not correct. You have to mention specifically what has actually happened, because the study has been completed. If some patients were lost to follow-up, there was some missing data, you need to mention them and need to justify them that why this has happened. Also, when you're reporting your protocol for the approvals, you should also mention about the timeliness. This will give a fair idea for you also and for the approval committees also, that whether you will be able to complete your dissertation in a fixed time, fixed frame, and hence the mention of a timeliness using either the text message or maybe a Gantt chart is very, very important. The ethical consideration must be mentioned that if whatever the interventions that you are doing, whatever the interventions or the procedures that you are withdrawing, whether there is any ethical issues about those concerns or not. The references must be in a Vancouver format, or as per the university requirement, you need to check. You also need to check the format that a particular university requires, and the format should also be done accordingly. But also always remember, it is always a good idea that anything which is being quoted into a study must be cited through a proper reference. And most probably, until there is some historical article, the references should be more latest one within last 5 years, but not more than last 10 years. Do report and add the various annexures into your dissertation. If you have used some questionnaires, some measurement tools, if you have obtained permission from the authors if they are copyrighted, the patient information sheet, the consent form in either languages which patient can understand. All those should be attached to your dissertation or the research protocol. Always remember that you have to also submit the brief summary of study, which are usually less than 500 words, in which you give in very brief the rationale, the study goals and objectives, the study design, the expected outcomes, methods, data management, and references for protocol. And in case if it is for the final dissertation, you should also report your results, your conclusion, what you have obtained from your study. The review of protocol is usually by the departmental committees, where various faculty of the department, staff of the department reviews your protocol and gives you an approval. And then subsequently, once the department approves, it goes to the ethical committee or the academic committee for the academic approval and also the ethical approval. And once the protocol is submitted, like this, which can be in a simpler format, and this format of the protocol submission needs to be followed, which could be as per the university dependent. So whatever the format is, please adhere to the format of a particular university or college, though they are principally similar, but the heading is a little different. You need to submit to the ethical approval member secretary, for the ethics committee, to the dean for the academic approval, and even some of the ethical committee will ask for the provisional registration, CTRI registration. So it is a prospective registration. It cannot be done retrospective. So always register your protocol once it is approved into the CTRI, obtain the number. And once you obtain the ethical approval from your ethical committee, you can start the study. And officially after the ethical approval, CTRI will formally give you a final registration number, because CTRI will require a copy of the ethical approval from your society, from your institute. And once the ethics approval for the protocol is done, the research begins, follow the work schedule. And during the ongoing research process, always keep the documents. It is mandatory to keep all the case record forms, the consent of the patient for at least 10 years, 5 to 10 years, depending upon the university. Like for us, it is for 10 years. We need to keep all the documents, especially the consent and the case record form. Now, once the research has been completed, it's a time to write the thesis or dissertation first. And for dissertation, these are the broad topics that needs to be followed. The title, the dedication, acknowledgement, abstract, which may be a little subsequent also. The content page, which requires the details of the main method section, in bibliography and the appendices. Now, just in brief, just to repeat once more, for dissertation, the title should be as per has been accepted by the ethical committee. If you want to change something, you should take approval from the ethical committee. Do follow the acknowledgements, write the abstract. The word limit may be different for different universities. Sometimes 300 words, sometimes 500 words also. And in the content page, I'll just take you to the next slide where I will add on the other things, and do all the bibliography and the appendices. The main body, the introduction, which I discussed earlier, should include the main focus, that what was existing, what was lacuna, and why you did this your research project, with focus, aims, and objective of your study. Write the background information with literature review. Method section should be in a great detail, and you can copy it from your protocol, which you have submitted earlier. But remember, sometimes the methodology may also, it will be good for dissertation purpose if you can add on certain pictures. If you have done some technique, like say, for example, say ultrasound guided blocks, you can put some pictures there and then go ahead, do for the results, analysis, conclusions, and recommendations. Now, title page, the formatting will be as per your institutional requirement. But remember, the title page, the heading, the title of your study should be as same as you have taken the ethical approval. Take the necessary certificates that are required from your institute, get them signed from each of your supervisors and co-supervisors with a stamp that gives approval that they have seen your dissertation, so that the reviewer knows that it has been approved by all the chief guide and the co-guides, or maybe the supervisor and the co-supervisors, and they have approved it. The acknowledgement, this is a usual a general acknowledgement, because over 2.5 years, you must have taken help your colleagues, biostatistician, maybe lab, maybe some ultrasonography. So try to acknowledge all those things, all those persons who are not part of your main study, but who has helped during the project. Introduction, we have discussed earlier. It may be updated if you have some newer studies which has been published by the time your protocol was submitted. You can update introduction. Otherwise, it may be as same as your research protocol that you have submitted. Literature review, again, it needs to be updated one, because it is a part of the newer, because in the time process of 2 years, newer studies would have been come into the publications, and you need to read those studies and put into a literature review to update what you have submitted earlier in the protocol. But remember, what is the important aspect from these is that whenever you introduce a literature review, you have to define or explain the problem, the conflicts, the time frame, your choice of source material, or you can use combination of these. This means the review of literature, if somebody wants to read in detail of your study, the whole components, whether it is related to the method section, whether it is related to the objectives, whether it is related to sample size, must be a component of your literature review in detail. And you need to organize the literature review very clearly. There are various ways of organizing your literature review when you document into a dissertation. It can be by subject. For example, say your ultrasonography machine, your blocks, your outcome measures. It could be chronologically. It could be by theme, idea, or maybe research studies. It may be by author or by argumentative stance, where you justify one point based on your objective. So whatever way you are, there should be some systematic way. Usually most of the dissertation will talk about the objectives, and then they talk about the method section. So if somebody is using, for example, say ultrasound guided tap block, so they will mention about the lacuna of the previous blocks, and then they will further go on to various stage of tap block, and then the ultrasound guided tap block, and they will document that this is why they have used it. Now, once you have collected all those material and once you are updating for the last 2 years, this is the important aspect. Whenever you collect data, because there will be n number of articles, you try to keep them appropriately, because once you have say 100 articles for you, you may not be able to track that this sentence has been copied from which of the articles and how to be cited. So always try to keep a track of these articles, you number them nicely. You mention the reference either with the author's name, or you can put some numbers to them, so that you, when you're finally writing your references or bibliography, you are able to exactly quote the same author's reference which you are being quoted there. Now, once you have written the review of literature, including each articles, you must write a concluding paragraph in the literature review, which concludes whatever you have done it. So it should summarize, contextualize, point at the gaps, and it should be a transition to the next section of method, which we'll be using now, or maybe terminating into the aims and objectives. The methodology, because since you have already submitted protocol and we have discussed in detail, so just copy it from your protocol, but always remember that you need to update it by some photographs, by some procedural photographs. For example, patient position, ultrasound photographs, block photographs, you can add on for better clarity when you're submitting your dissertation. The result section, now this is a new thing which is not a part of your protocol. You need to look for the results, and always try to have, if it's an RCT, try to have a flow of study, that how many patients were assessed, how many patients were recruited, how many patients completed the study, analysis were done. So you should need to have a flow of study. For RCT, we say consort chart. Otherwise, even for observational study, you should mention it. State all the findings, whether they are significant or not, whether they are positive or negative, without bias, and there should not be any interpretation here. And the order of these results should be as you have mentioned in the method section. Usually we start with the demographic profile, then the primary objective, and then the secondary objective. And then subsequently, you confirm whatever you have hypothesized initially into your previous protocol. While you're reporting the results, do use past tense in your dissertation. Now, sometimes there is a confusion that sometimes you try to interpret the results in the result section. So the results, you just state the results that has come up from your study. And you have said maybe whatever the statistical tool to summarize your data, or for inferential statistics to compare the data, just mention them. You don't have to interpret or discuss it that this is beneficial, then this because of this effect. This will come later section. All the patients must be accounted for. If you have recruited 100 patients, report 100 patients in results, because if there's some discrepancy that your sample size was 100, you mentioned results of 90, you analyze only 60 patients, the reason for this must be clearly documented in the results section. Now, in results, don't regurgitate the data. I said you have to use some meaningful sentences. If you see the difference between two headings, the first one, this is not correct. And for patients, treatment group contained 40 patients. So these are just not describing the individual data. So these are not called results, these are called data. We need to transform information, and they should be in some scientific language. So the more appropriate thing would be, there were no significant differences in the treatment and the control group in patient intake for demographics. And hence and henceforth, you should document it in a more scientific manner. Now, the tables and figures are the important aspect. You need to differentiate where to use tables, where to use figures and text. Though it has been seen in presentation that there is a duplication of the data into tables, figures, and text. This is usually not required. So you need to choose one, either the table or the figures or the text. And whenever you are reporting the tables, you also need to document them properly. The titles, the headings, the legends, they should be properly labeled. In tables, the legends is written on the top of the table, and the of each rows should be mentioned clearly. For the figures, the legend is written on the below the figures, and each component or the various lines that you are using, they must be labeled that for this is exists for which group. And also you need to remember, if you are using mean standard deviation, if you can see these graphs here, the mean and standard deviations are being reported here. So x-axis, y-axis, and all the labeling should be done appropriately as per the requirement. Now, remember, once you have those figures and tables, you can summarize them into a text. There is no need to repeat them in totality in various formats. So whatever you have answered your original questions, your direction for future studies, and both of which belong in the discussion, you need not to be mentioning those details in the results rather than the discussion. But remember that once you have figures and tables constructed, try to summarize in the text and cite your tables and figures in the text rather than duplicating them. Remember, do not use tables when data can be summarized briefly in the text, when the relationship of data or trends can be shown more clearly on graph. So use on those situations your graph situation. And do use tables when readers want exact values rather than a graphical representation. So you need to mention it. Like for example, if you see this data here, there are so many numerals here. So probably if you put it in the form of table, probably it will look more clear. Also remember, when you are reporting them, your studies, you should, whatever different groups you are using it, when you're taking print of your dissertation, you should assume that the color combination should be appropriate so that different group remains in different color. So accordingly, you should mention it in proper way. Sometimes we need exact values, sometimes we need trends. So probably for trends, figures are good. If you need exact values, the tables would be much better in those situations. But remember that the combination of text, tables, figures, and graphs should be as per your data. And there's no fixed rule that dissertation would require only text or the table figures. The combination has to be used as per the requirement. Now, discussion section is important because it requires a lot of interpretation. Now, if you see the overall discussion component or chapter of your dissertation, you start with your key findings and then explain each point coming for the first primary objective and the secondary objectives, and interpret them in the context of the existing evidence and explain the clinical relevance and implication of these findings. And then subsequently, you should mention the strength of your study and the limitation, because you have done study, you may have find that this study may not be applicable for obese patient, they may not be applicable for pregnant patient. So you know your limitation, you need to mention it, and based on this, you can even suggest future directions. Now, this is important because sometimes we go on adding more things in discussion. In dissertation, there is already a column of review of literature. So discussion is not review of literature. Discussion is more of the interpretation of the other studies on the background of your outcome data. And hence you should be very brief and interpreting it. And that's why you may require at times the help of your guide or the experienced person to interpret those data accordingly. Also remember that no new results should be introduced here. Conclusions and recommendation must focus only on the aims or objectives of your study. And the results should not be generalized too much for all patient population. If you have done your study in adult patients from 18 to 45 years, you cannot generalize it for even for the elderly population. If you have done patients on a normal BMI patients, you cannot extrapolate it to the obese patients. And don't try to extrapolate it. Whatever you have planned, whatever you have done it, you should discuss into the discussion section, nothing else. The subsequent part of your dissertation is the conclusion. You conclude your study based on your objectives and hypotheses. Nothing else, no new outcomes, no presumptions. What you have done, what you have previously decided, you need to document only on those things. And then finally, you add on the references. I mentioned earlier, preferably in the last 5 years, add one reference for approximately 100 words and use most relevant references only as a part of your references. Most of the dissertations and most of the universities will ask you for a summary or a synopsis, maybe a part of your dissertation or a separate booklet of a summary. And when you write a summary, basically once you have written your complete dissertation, it will be easy for you to summarize it. And this synopsis should include title, introduction, aims, objectives, methodology, statistical analysis, including sample size, discussion in brief with limitations, followed by conclusion and references. So sometimes depends upon the university, it could be as small as 500 words, and some universities may ask it for 1500 words. So it has to be truncated with keeping these points in focus for your synopsis. In your dissertation, you need to mention the various appendices, which can be the case record form, your master chart, where you have documented all the data, the patient information sheet in various languages, consents, approvals, and permissions. So these all should be mentioned as a copy into your appendices. And now is the time to submit your thesis for external review to your college or your university. So when you write a thesis, it has to be signed by the chief guide, by the co-guides, by the head of the department, by the head of the institute, and they are submitted to the exam section, which they send to the reviewers. And when they review the thesis, majority of time, it will be basically acceptance, because probably you have been rightly guided by your supervisor. And if you have followed all these things which we have said earlier, it will be accepted. But in case if there are some, if you have missed something, usually majority of time we observe that various components which we have discussed in the method section or the result section, or sometimes the interpretation, there is some issues, they are sent back for revision. And once we receive the dissertation for a revision with some points, you should go for those points and try to analyze or try to correct those lacunas into your study and resubmit it. Probably it will be accepted. But if you remember all those points which we have discussed in last 3 sessions, probably there will be no reason for your thesis not to be accepted. Having said that, I will not stop at dissertation. You should submit papers as early as possible for publication also into a journal, because if you have published your article at the time of an exam, it gives your sanctity, just not for the external review, but during the exam. If you have published your paper, it will be an additional boost to you that whatever research you have done was of a standard and it has been accepted. But you need to follow the university rules. Some of the universities allows the publication to be done before the exam, some allows after the exam. So follow the rules, but be prepared always to submit your research so that it helps others also. Do carry your dissertation copy, do keep your dissertation copy always with you, because sometimes in your exit exam, in your interviews, the examiner or the interviewer will like to see your thesis copy. Though it's time of now the e-copies and the soft copies, but you should always keep your copy and do carry them into your final exit exam. So that if the examiner wants to see, because maybe the examiner is same who has reviewed thesis, they want to clarify something, you should have a copy of your thesis during the exam section also. So my best wishes to all the students who are looking here for our sessions today. And now we are open for any questions, any comments from any of us. Thank you so much.
Thank you, Rakesh sir, for your wonderful narration of how to write the dissertations. So we come to the end of this session. Balabhaskar sir, there are only few questions. So shall we take the questions? So first question is, the CTRI is only for the RCTs, sir. What about the observational studies?
The CTRI is a registry, as I was discussing, registry for the research proposal from anybody in terms of biomedical research. So whatever I do, I can submit to CTRI. It is just like a repository. They store it, whatever we have done, whatever you have submitted, and it is available for people to see across the world. It could be within India or outside India, and people can see what is happening with respect to that particular field. So that way, there is nothing like mandatoriness. But mandatoriness is with respect to the submission for a prospective study. So for randomized control trials, we must submit it, get approval. Only after it is approved, then we have to start recruiting the patient for a randomized prospective trial. So that's the most important thing. And of course, even retrospective studies can be just registered. It will just take up and store it basically. And observational studies, any type of observational studies, single group studies, two group studies, it will also take up. And then with respect to the case control cohort studies also, it will accept. So main aim of the registry is to see that, number one, everybody has got an access. Academicians have an access to an ongoing research in medical field, and the lay public also have got an access. So that's the reason it will ask for contact details from us, that who is responsible to answer any query from the laypersons of the public. And we are also expected to put a title for lay public. So instead of an academic title, we also put a title for the sake of the public to view it. So for randomized control trial, it is definitely, because it's prospective, you must get permission before we start. And finally, when we want to submit the articles for publication, majority of the journals, irrespective of the design of the study, would expect registration in the clinical trials registry.
Okay, so the next question is, you have mentioned the pilot study is not for sample size, but how to get a sample size in a newer topics where the effect size is not known?
Yeah, so one thing is, the first statement is true. So in the sense, the pilot studies cannot be used to calculate the sample size. It doesn't have a statistical standing with respect to using it for calculating the sample size. But on the other end, the literature definitely says our experience would always be useful in the particular field. We are trying to get evidences from the literature with respect to a new drug or a new technique. Definitely, it may not be available, but existing drug or an existing technique is always there, and the new drug is always something which is different from the old drug. So we can always assume that the new drug could be better than that, or sometimes we talk about what is known as equivalence, non-superiority or non-inferiority with respect to a particular drug. So based on that also, we can decide upon the sample size. And in those situations where superiority is to be considered, it is said that even we can use our own wisdom and knowledge. Yes, so if I am into the academic field for a sufficiently long time, I am allowed to think logically, of course, based on the background academics. Yes, this can be the hypothesis, and based on this hypothesis, either null or alternate hypothesis, this can be the assumption of the effect size, and this can be the sample size. That is done, accepted.
Yes, sir. Okay, thank you, sir. So the next question is to Dr. Sudhis. How to assess the quality of analysis here? So this is not there, sir. How to assess the quality of analysis?
Yes, yes.
Hello, sir.
Sudhis, sir.
Yes, sir. So there was some network problem. I was not able to. Yeah. So what was the question, sir? Sorry.
How to assess the quality of analysis here? We know the duration of analysis, yeah?
Yeah, yes, sir. Sir, actually, the quality of analysis here, there is no one tool. Most of the tools as of now are all subjective tools, sir. Either numeric rating scale or visual analog scale, or in pediatrics we have various type of scoring system based on their faces, smileys scale or whatever it is. But so that is the only way we can assess the quality of pain, which can be measured, quantified. Again, we have to quantify that, sir. So using any of these methods. Otherwise, the subjective assessment is very difficult. They can either say yes, they can either say no. but there is no method to say that this is the objective method of measuring the pain. We are just converting that subjective measure into trying to give some objectivity by using this VAS scores or numeric scale, rating scale or anything like that, sir.
Can we do the average NRS score like that at the end of?
Yeah, that's right, sir. That's right, sir.
Okay. Sir.
That was the thing, sir. That is the thing. That
okay.
is the thing what
so,
we do. When
the last question is, what is block randomization? What is block randomization by Dr. Block randomization.
Yeah, so the block randomization is again a method of randomization technique where we take blocks of numbers, like a block of 4, block of 5, block of 6 numbers, and again you like what we did in this one, you assign a particular number so that let us say 1 to 4 group A, 5 to 9 group B, and in that particular block you assign them into group A or group B depending upon where the number falls. So like that, we take individual blocks. How many ever, suppose if we are involving 60 patients in this group, we can take 10 blocks of 6 students each, like that. So we can, and then we can take that. So this block randomization, the advantage is that it ensures uniform distribution in both the groups. And even if there is any fallout or anything like that, this block randomization can result in there is ensuring that equal number of participants are present in both the groups. There is no there is always there is a possibility that one group can end up having more patients towards the end of the study and the other group having less number of patients because of some other issues. This block randomization eliminates that problem. So therefore it ensures that both the groups have almost same number of patients and discrepancy is not creeping in. So therefore that selection bias and the randomization bias is avoided in that.
So the last question to Ragesh, sir. Sir, in dissertation, the language checking is whether it is necessary as like in publications.
Definitely, sir. I think plagiarism checking has been made mandatory for each aspect, even for protocol submission, even during dissertation and publication. So it is mandatory at many institutes that we have to submit a plagiarism report for the various aspects. On the other hand, even if it is not mandatory at some college or institutes, I think we should be cautious not to copy because it's an intellectual property of somebody. So we should be cautious not to copy them because we said that dissertation thesis is to inculcate a research habit and writing, both the things. So I think from the beginning itself, as supervisors and as a guide, we should try to inculcate a good habit that they should read the literature and they should write in their own language. And if it is an idea or a document or some fact is by somebody, they should cite it by after writing in their own language. So I think this habit should be started from the thesis itself.
Thank you so much, sir. On behalf of postgraduate, the online anesthesia is profusely thankful to Dr. Balabhaskar sir, Dr. Sudhis, and Dr. Rakesh for wonderful presentations. Even though we are extended our time beyond 1 hour, it is more, I think it is more useful to the postgraduates. At this juncture, I thank the A1 Logics for giving the opportunity for extend 1 more hour. I thank the A1 Logics Shilpa, and I thank the that is the sponsor, that is Akurala, and also the Anaesthesia TV. Thank you, one and all. We will meet the next week with obstetric anesthesia. Thank you, sir. Thank you.
Thank you, sir. Thank you so much, sir. Thank you so much.
Thank you. Thank you so much.